السلام عليكم، كيف الحال؟
عاوزنا اخليهم يخلصوا.
الصوت عندي مو واضح، يقطع. السلام عليكم. أنا الصوت عندي مو واضح. أنا عندي برزنتيشن المفروض من 8 دقائق إني أبدأ. أنا معاذ الغدير من الرياض، فما أدري نبدأ الآن ولا متى نبدأ ولا كيف الترتيب.
السلام عليكم يا دكتور معاذ.
وعليكم السلام ورحمة الله، أهلا وسهلا.
انا الدكتور محمد خطاب يا دكتور معاذ، ازيك يا حبيبي؟
أهلا وسهلا، حياك الله.
احنا هنبدا لسه الساعه 6، يعني احنا عندنا يعني 20 دقيقه تو ستارت، لسه ما بداناش. احنا لسه
تم.
هنبدا الساعه 6 بتوقيت القاهره، يعني احنا سابقين. احنا لسه ما بداناش، هنبدا الساعه 6.
أنا كان عندي مسجل إنه الساعة. طيب أنا الساعة 6:30 حيكون عندكم. إحنا عندنا الآن الساعة 6:30، عندكم الحين الساعة كم؟
الساعه 5 ونص و5 دلوقتي.
آه،
لسه
أوكي.
لسه ما بداناش.
طيب، يعني أنا I will join you على الساعة، يعني بعد تقريبا ساعة من الآن، صح كذا؟
نص ساعه وجوين. انت عندك حاجه؟ انت مشغول يعني؟
لا.
خلاص نص ساعة وجوين، احضر معانا من الأول. هو هيبقى في محاضرتين للدكتور وائل قبطان، وبعد كده أنت على طول.
طيب سؤال، أنا الآن البرزنتيشن تبعي عندكم، ف someone from your side will present the slides وأنا أقول له next next، مظبوط كذا؟
لو أنت عاوز تقول لايف على طول أوكي. لو أنت عاوز
والله صوتك راح يا دكتور.
معاذ، انا معايا البرزنتيشن بتاعت حضرتك وهنعرضها، وحضرتك بنهايه كل سلايد هتقول نيكست واحنا هنقلب مع حضرتك نغير
تمام
السلايد.
كذا؟
تمام مفيش مشكله. انا معايا
طيب
البرزنتيشن
توكلنا على
بتاعت
الله.
حضرتك.
معناها على الساعة 6 بتوقيتكم نبدأ بإذن الله.
إن شاء
ان شاء
الله
الله.
تلت ساعة من الآن.
طيب خلاص، إحنا نصلي المغرب وبعدين نبدأ نجيكم إن شاء الله.
ربنا يتقبل، ادعي لنا معاك.
شكرا جزيلا.
مصطفى ولا عبد العزيز اللي معانا دلوقتي؟ مصطفى.
مع حضرتك يا دكتور.
مين، مصطفى ولا عبد العزيز؟
ايوه مع حضرتك، انا مصطفى. ايوه مع حضرتك.
ازيك يا مصطفى؟
ازي حضرتك يا دكتور؟ ازي حضرتك؟
بقول لك ايه، انت كده عندنا النهارده دكتور بارون مسجل محاضرته، مش كده؟
دكتور وائل. دكتور وائل.
دكتور وائل مسجل محاضرتين،
بالظبط.
ودكتور معاذ عندك المحاضره بتاعته اهو بيقول لك.
معايا الباوربوينت للدكتور معاذ، انا هعرضها
باوربوينت
معاك.
بس.
بالظبط كده.
طيب تمام.
دكتور بارو.
اه
ومعايا ريكورد دكتور احمد شوقي.
طيب اوكي ماشي الحال.
تمام.
دكتور وليد قشطه هيقول لايف.
بالظبط هيبقى معانا.
طب تمام، انا هحاول ابعت لهم دلوقتي رسائل ان احنا هنبدا بعد ان شاء الله ربع ساعه. اوكي شكرا.
مساء الخير. هو صوتي وصل لكم ولا؟
دكتور شريف سامعين حضرتك.
حضرتك واصل يا دكتور شريف.
المطلوب مغلق أو غير متاح، يمكنك إرسال.
السلام عليكم يا محمد، ازيك؟ هنبدا بعد ربع ساعه. مصطفى لو سمحت allow الكاميرا for the panelist please. مصطفى
تمام يا دكتور محمد، اتفضل عملنا عليه.
ماشي شكرا. السلام عليكم دكتور وائل، ازي حضرتك؟ مصطفى
الو،
استنى. دكتور وائل بيه ازيك يا فندم؟
ازاي الصحة؟ ازاي جنابك؟
ازي
ايه الاخبار يا
حضرتك؟
بيه؟ كله كويس
وحشنا
بخير؟
كتير، وحشنا
انت
كتير يا بيه
اكتر يا بيه
والله.
والله، يعني ومجهود رائع يا محمد، ربنا يكرمك كبير ويخليك، حاجة رائعة والله. انا متابع
ربنا
على فكرة almost every day، يعني بخش يعني as much as I can يعني، والحقيقة very 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 impressive الحقيقة، ما شاء الله.
ربنا يكرمك يا بيه، ويعني متشكرين جدا لدعم حضرتك والسبورت بتاع حضرتك يعني.
It's my pleasure يا بيه والله، it's my pleasure.
ربنا
قول لي
يخليك.
احنا هنبتدي on time
هن...
ولا احنا
هن...
في delay
لا لا
ولا في ايه؟
لا 6 بالظبط بنبدأ إن شاء الله. وهو يعني المعتاد إن مع الوقت الناس بتبدأ تدخل. احنا دلوقتي
تمام
عندنا 33 اتنديز موجودين تقريبا،
تمام.
والمعتاد إن احنا
احنا
بنوصل 100 وشوية كل يوم يعني.
انا متابع. لا شفت ارقام ما شاء الله. يعني اقل رقم شفته كان مثلا حاجه و90 ووصلنا ل 100 و100 و120 وكده يعني. which is يعني
الحمد
ما شاء
لله.
الله برضه
الحمد
انا
لله.
achievement في الظروف دي هيت يعني. وبعدين برضه انا لاحظت ان في يعني مش بس من مصر، يعني في من اماكن تانية يعني
الحمد لله، دي حقيقة.
which is دكتور يوسف في امريكا على حسب ما انا فاهم، صح كده؟
لا موجود.
في مصر في القاهره.
موجود.
انا
ده هو
وصلت لي اشاعه كده ان
اعتقد.
هو في امريكا.
لا موجود.
اوكي. لا اصل
موجود.
يعني هو انت ممكن تبقى في
صح.
امريكا يعني
دي ميزة الفيرتشوال فعلا.
دي مثل الفيرتشوال بالظبط كده.
بالظبط.
كويس. حلو 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 حلو. ربنا
والله.
يكرم.
هو احنا المفروض ان هو يعني يكون دخل. انا هكلمه كده اشوفه فين، ولو كده هنشوف هنعمل ان شاء الله.
هو انا بقول لك، انا الميزه ان المحاضرتين بري ريكوردد، فما
ايوه،
فيش
انا كتر خيرك.
مشكله. ده
كتر
ده
خيرك
ده
فعلا.
ده, 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 ده اسهل حاجه على فكره. انا يعني انا بعد ما سجلتهم الحقيقه يعني it is extremely comfortable
بالظبط.
ليا وللادمنستريشن، للناس اللي
دي حقيقة.
يعني فاهم. انت بدل ما تقعد شايل هم، لا ده الانترنت لا بطيئه لا سريعه، لا ده دخل اون تايم، لا ده دخل متاخر، لا ده النت وقعت. فاهم الحاجه متسجله عندك، واحنا الاسئله في جميع الاحوال بتبقى في اخر السيشن خالص، فما
بالظبط.
عندناش مشكله. فاهم.
دي حقيقة فعلا. ويمكن اول يوم كان معانا 2 من الزملاء كان الانترنت فيهم مشكلة فعمال يقع وندخل حد تاني وهكذا. ففعلا البري
بالظبط.
ريكورد دي حاجة فعلا
انا
رائعة.
انا ايفن حتى الانترودكشن يعني بشكر الدكتور يوسف وشكر بيت وكده، انا مسجلهم على المحاضره. فانت يعني قصدي كان
انا
ستارت على
هكلم
طول.
دكتور يسري لحظة واحدة يا دكتور وائل، لحظة
خلاص
واحدة.
شو يا محمد، شو يا حبيبي.
هو بيساين ان اهو يا دكتور وائل، بيساين ان على طول دلوقتي. تالي يو ار ميوتد دكتور وائل.
يا بيه كده
كده سامعين حضرتك تاني. هو
مرحبا دكتور محمد، مرحبا دكتور وائل.
وائل.
دكتور وائل
اهلا يا فندم، اهلا وسهلا.
وائل القاسم سباين كونسلتنت فروم سوريا، بس وركينج ان اربيل العراق. من الناس
يا
اللي
اهلا
ما شاء الله
وسهلا.
اكتف جدا يعني.
يا اهلا
الله
وسهلا، اهلا
يسلمك، الله
وسهلا.
يسلمك
بلاجر يا
دكتور وائل.
فندم، بلاجر والله.
هو مساء الخير عندك، يمكن عندي لسه انا افترنون. السؤال عفوا، انا بدي هي موضوع الريكورد. هو ريكورد على نفس الزوم نفسه، على نفس الابلكيشن؟
لا يا فندم، انا بريكود على الباوربوينت، وبعدين بتحولها لفيديو، وبعدين تبعتها للجنه، هم يعرضوها من عندهم. فكده تضمن ان الكواليتي بتاعت الصوت والكده ما فيش بقى حاجه بتقطع ولا النت
يبقى
رجعت.
الريكورد بالاول على الباوربوينت مش على الزوم نفسه.
يس ده اوبشن
تمام.
موجود دلوقتي. حضرتك بتسجل المحاضره، وممكن تسجلها حتى صوت
واي
وصوره يعني
فاي.
ممكن.
حلو كثير. راح نطبقها ان شاء الله تعالى.
يس اتس فيري يوسفول.
وائل،
دكتور يسري وحشنا يا باشا.
انت
ازاي
كمان
الصحه يا فندم؟
والله. ازيك يا حبيبي، عامل ايه؟
ازاي الصحه يا باشا؟ ازاي حضرتك؟
اهلا بكل الوائلز اللي موجودين في الليسته.
الله يسلمك استاذ.
ازيك يا وائل، عامل ايه؟
الله
ازاي
يسلمك.
الصحه يا فندم؟
ازاي
ازاي
صح
حضرتك؟
كده؟ الله
انا
يخليك.
كان عندي اشاعه ان حضرتك في امريكا، ما اعرفش بقى دي طلعت اشاعه غالبا يعني.
لا لا هنا. انت عامل ايه؟ كويس؟
انا بخير الحمد لله، كله
الحمد
جميل
لله.
الحمد لله.
دايما
ميرسي يا بيه جدا
منورنا
والله.
كده والله.
يا بيه ده بنور سيادتك والله. انا مش
الله
يعني
يخليك.
ممنون على الدعوه جدا والله. It's a real
الله
pleasure and an
يخليك.
honor to be part of this program يعني.
الله يخليك. قول لي انت، اتس كيس اورينتد برزنتيشن ولا اتس توك؟
لا it's a talk.
Okay.
اتس توك.
Very
فما فيها جزء بيزك وجزء حالات يعني من ده.
Very good. لا متعنا as usual يعني.
ربنا يخليك يا بيه، ده بس
إن
بتذوق
شاء
حضرتك
الله.
والله العظيم.
ان شاء
ربنا
الله يا
يخليك.
حبيبي.
ربنا
انت
يخليك.
هتبتدي بالشوارع صح؟
حضرتك هم الاثنين بري ريكوردد، الاثنين متسجلين، فهم دي ويل سيمبلي ران ذم، هيشتغلوا على طول.
Excellent. Very good. خلاص يا محمد خطاب.
وانا مع حضرتك
ان شاء الله.
ان شاء الله يا
محمد.
فندم.
ايوه بيتفضل حضرتك.
يا حبيبي.
ازيك يا
جاهزين؟
بيه؟ اتفضل يا بيه حضرتك. قدم بقى دكتور وائل ونبدا على طول ان شاء الله. اتفضل.
Hello everybody. It's our pleasure to have you for the. Is it the 5th or 4th يا محمد؟
5th.
5th day.
لا هو الفورث داي، الفيفث انترناشونال فيرتشوال.
Okay. So it's a pleasure to have you for the 4th day in the 5th Scoliosis Week, and this session will be on different types of scoliosis, how to tackle them, and we are very glad to have the first speaker, Professor Wael Koptan. Professor Wael Koptan is the Professor of Orthopedic and Spine Surgery, Cairo University. I have the honor to say that Professor Wael was my spinal fellow 20 years ago. So this is really an honor for me.
It's my pleasure and my honor.
Professor Wael will start there are two talks. The first talk will be on Schwann's kyphosis, and the second will be neurofibromatosis scoliosis. Go ahead, Wael, please.
I would like to thank my dear professor, Dr. Yusuf Al-Hawwawi, for his kind invitation.
مصطفى.
مصطفى حصل حاجة؟
هكلمهم انا يا دكتور شريف.
Good evening, everybody. I would like to thank my dear professor, Dr. Yusuf Al-Hawwawi, for his everybody. I would like to thank my dear professor, Dr. Yusuf Al-Hawwawi, for his kind invitation to participate in this year's Scoliosis Week. I would also like to thank Dr. Mohammed Fawzi Khattab for his great efforts in organizing such an event. In 1920, Schwerman described a rigid kyphosis of the thoracic or thoracolumbar spine occurring in adolescence. This deformity appears just before puberty, with an incidence ranging from 0.4 up to 8%, and with a similar male to female predominance. Sorensen in 1964 described his criteria for diagnosing Schwerman's disease as the presence of anterior wedging of 5 degrees or more in at least 3 adjacent vertebrae at the apex of the kyphosis. Other findings include irregularity of the end plates, elongation of the apical vertebrae, the occasional presence of Schmorl's nodes, narrowing of the intervertebral disc spaces, and this deformity could be associated with mild to moderate scoliosis in 30% of patients. So, is Schwann's disease a hereditary disorder? Well, there are several reports of aggregations of Schwann's disease in families, suggesting a hereditary character with an autosomal dominant inheritance. There is also a high concordance of Schwann's kyphosis in monozygotic twins. So why do we treat patients with Schwann's disease? Well, because it's frequently confused with postural kyphosis, which may lead to a delay in its treatment. And unfortunately, patients in whom the disease is not recognized before skeletal maturity may have a severe deformity with resultant pain and rarely a neurological deficit. This study had a 40-year follow-up of patients with Schwann's disease that were treated conservatively. It included 38 patients, and the authors concluded that there is a lower health-related quality of life in the domains of pain and self-image, and an overall tendency towards lower quality of life. Clinically, Schwann's kyphosis has several classic features: an angular thoracic kyphosis with a compensatory lumbar lordosis and an increased cervical lordosis. All of these lead to forward protrusion of the head on the trunk, the classic goose neck appearance. There is also anterior positioning of the shoulders, and the deformity is relatively fixed. Radiological examination, of course, includes X-rays of the whole spine from skull to pelvis in the AP, lateral, side bending, and flexion extension views. And you should also perform an MRI of the whole spine. And why is that? Because intraspinal anomalies can be found in Schwann's disease. This publication from the Asian Spine Journal, published a couple of years ago, included 120 patients, 6% of which had an intraspinal pathology in the form of a syringomyelia. And the authors recommended that all patients with Schwann's disease should be evaluated using MRI of the spine before corrective surgery. Another reason is the rare but very important occurrence of a thoracic disc herniation causing cord compression at the apex of the kyphosis. Recently, surface topography was used to evaluate patients with Schwann's disease, and this can give us several important values like the kyphotic angle, lordotic angle, pelvic obliquity, truncal length, and so forth. So what are the indications for treating these patients? They are what I like to call the 4 Ps. The first is pain. The second, if the deformity is progressive. The third is the psychological effects of this deformity on these young adolescents. And finally, if there is a neurological deficit in the form of paresis. We start usually by conservative treatment, and this includes brace treatment and physiotherapy. Brace treatment, unlike that in idiopathic scoliosis, can result in permanent correction of the vertebral deformity. but there are several prerequisites for a successful brace treatment. The deformity has to be between 50 to 75 degrees in a skeletally immature patient who is highly motivated to withstand the prolonged periods of bracing, and the curve has to be flexible. A lateral X-ray in the brace should show correction of the deformity to within the normal range. One of the earliest publications on the use of the Milwaukee brace in treating Schwerman's disease was by Dr. Bradford and his colleagues. Their study included 223 patients, of which 75 completed the treatment protocol and showed improvement of kyphosis, vertebral wedging, lordosis, after an average of 3 years in brace treatment. At that time, the fabrication of the brace took almost 1 month. If the curve was rigid, this time was spent in a visor anti-gravity cast, which included the neck. When the brace was applied, a specific exercise program was initiated and the patient was checked with lateral X-rays in the brace every 4 months. Gradual weaning was begun when maximum correction was achieved, vertebral wedging decreased, and the patient was nearing skeletal maturity. The authors had a follow-up study later on, but this time it included 274 patients, 120 of which were followed for at least 5 years. 76 patients showed improvement in the deformity, 24 were worse, 10 were unchanged, and the remaining 10 were inconsistent in their use of the brace. The main problem with bracing, especially with the use of the Milwaukee brace, is that it's cumbersome, unsightly, and uncomfortable for the patients, which led to diminished compliance. Actually, in this publication in 1988 on 75 patients with adolescent kyphosis that were braced using either the Boston brace or the Milwaukee brace, 31 patients completely rejected the orthosis within 4 months. So to improve the patient's quality of life while wearing the brace, and by that improving compliance as well, several attempts were made to reduce the material of the current braces and improving them without losing the in-brace correction desired. And these modern braces were developed and applied in Schwerman's kyphosis patients. And with these new braces, compliance improved significantly, and the results of brace treatment were significantly better. Bracing must be associated with physical therapy or physiotherapy, and several studies reported that adolescents with Schwerman's disease who had physiotherapy showed significant improvement both in cup angle and in pain. So when is surgical treatment indicated? It's indicated for curves 75 degrees or above. And the main aim for treating these patients is to stop progression and also to achieve a good correction. Several types of instrumentation were used in conjunction with posterior arthrodesis. It started by the Harrington compression instrumentation in the 70s, but this was complicated by prolonged periods of casting and occasional rod breakage. Later in the 80s, Luque instrumentation was used, but this was associated with a high incidence of neurological injuries and the occasional occurrence of junctional kyphosis. Later on, with the introduction of hybrid constructs in the form of hooks, pedicle screws, and sublaminar wires were used for a two-staged fusion and instrumentation of these patients, and several studies reported correction using multi-segmental hybrid instrumentation in patients with Schwermann's kyphosis by a front and back procedure. But this had several complications, the most important of which is pulmonary complications, which occurred in almost 40% of these patients. With the introduction of the all-screws constructs, this led to their use in treating Schwermann's kyphosis, and the earliest publication was by Dr. Lenke and his colleagues in 2006 in a study that included 18 patients who had posterior only all pedicle screw constructs and 21 patients who had a front and back procedure, and these patients were followed for a minimum of 2 years. Patients who had an all pedicle screw construct had less operative time and less intraoperative blood loss. They had a better correction that was maintained with significantly less complications. After that, Dr. Baron Lohner and his colleagues published their series of 78 patients with Schwermann's disease, 42 of which had a combined front and back procedure, compared to 36 patients who had a posterior-only surgery, and they concluded that the combined procedure resulted in slightly better maintenance of the kyphosis correction, but it also resulted in a higher rate of complications. In 2009, we published our own series of all pedicle screws in Schwermann's kyphosis. Our study included 33 patients, 16 of which had a single-staged all pedicle screw construct, and 17 had a two-staged hybrid construct. In the all pedicle screw group, we achieved better correction with less operative time, less blood loss, and less hospital stay. In these patients, we performed Ponte osteotomies at several levels at the apex of deformity and above and below. We placed our anchors proximally and distally, contoured our rods, placed them in the proximal construct first, and then with a gentle cantilever effect, pushed down on the rod till we achieved the correction acquired. And this is an example of one of the patients from our study, a 15-year-old male with a deformity of 93 degrees that was corrected down to 46 degrees, and this correction was maintained during his follow-up. And these are his clinical pictures. So, is anterior release still useful in Schwermann's disease? Well, according to this systematic review of literature and meta-analysis published in 2017 and included 23 studies that were divided into two groups, a front and back group, and the second group had posterior only surgery. Similar outcomes in cosmetic improvement, pain relief, and loss of correction for both groups was found. However, the posterior only group had advantages in blood loss, operative time, the occurrence of junctional kyphosis, and revision rate. Junctional kyphosis is one of the common complications that can occur in Schwermann's disease, whether proximally or distally, and it's defined as a kyphosis of more than 10 degrees compared to the pre-operative value. Junctional kyphosis may be secondary to incorrect selection of the optimal fusion levels, whether proximally or distally, disruption of the posterior tension band during surgery, or the natural progression of the kyphosis with aging. This interesting study, published a couple of years ago, compared 3 methods for selecting the distal level of instrumentation in Schwann's disease. They compared patients who were instrumented down to the first lordotic vertebra, or to the lower end vertebra, or to the sagittal stable vertebra. And the authors concluded that selecting the distal fusion level proximal to the sagittal stable vertebra will increase the risk of distal junctional kyphosis, and this may become symptomatic and require revision. So, Schwann's disease is the most common cause of hyperkyphosis in adolescents. Its true etiology remains unknown, but there appears to be a strong genetic contribution. When recognized early in adolescence with progressive deformity, tracing will usually result in good correction. However, symptomatic adolescents with a severe deformity have good correction following surgical intervention. Thank you very much.
Thank you very much, Professor Wael Qubtan. Clear as usual. And we leave the questions at the end of the session. And can you proceed with your next talk on neurofibromatosis scoliosis?
Will be discussing spinal deformities associated with neurofibromatosis. Neurofibromatosis is the most common single-gene disorder. It is even more common than Down syndrome, and it's well known for its peculiar cutaneous manifestations. One of the most famous characters in the literature that had both a spinal deformity and neurofibromatosis was the famous Quasimodo from The Hunchback of Notre Dame. There are several types of neurofibromatosis, the most important of which is type 1, which affects both the ectodermal and mesodermal tissues. Neurofibromatosis type 1 is one of the most common hereditary disorders, with a prevalence of 1 in 3,000. There are strict criteria for diagnosing a patient with neurofibromatosis, and this is based on the presence of 2 of any of the following 7 criteria. The first is the presence of café au lait patches, which have to be more than 1.5 centimeters in diameter and at least 5 in number. If there are 2 or more neurofibromas of any type, or 1 plexiform neurofibroma, if there is freckling in the axillary or inguinal regions, if there is an optic glioma or Lisch nodules, if there is pseudoarthrosis of a long bone like that of the tibia, and finally, if there is a first-degree relative with neurofibromatosis type 1. If you find 2 or more of any of these 7 criteria, this is diagnostic of neurofibromatosis. Spinal deformities in patients with NF type 1 were first described by Gould in 1918. This is over 100 years ago. It has a prevalence ranging from 7 up to 63%. Dr. Akbarnia in 1992 published his work on 332 patients with spinal deformities and found an overall prevalence of neurofibromatosis of 10%. Several studies try to explain the main reason behind the development of spinal deformities in neurofibromatosis type 1. These theories included the presence of a primary mesodermal dysplasia, the presence of a neurofibroma in the concavity of the curve, dural ectasia, endocrinal disturbances, or even the presence of osteomalacia. Assessing a patient with neurofibromatosis needs a multidisciplinary approach. You have to take a full history that of course includes a full family history. You have to thoroughly examine these patients, and this must include a thorough neurological examination. And you should fully investigate these patients, and this must include plain X-rays, an MRI scan, and occasionally you can need a CT scan. There are 2 types of spinal deformities that can occur in patients with neurofibromatosis type 1, the non-dystrophic curve pattern and the most common dystrophic curve pattern. The non-dystrophic curve is a benign-looking curve in a patient with neurofibromatosis type 1, which behaves just like an idiopathic curve, but it has a higher risk of curve progression. So, accordingly, it is treated with the similar lines of treatment to that of idiopathic scoliosis. The dystrophic curve has clear changes in the vertebral column and in the thoracic cage. And we'll go through these dystrophic changes. The first and most commonly found is that it is a short, sharply angulated curve that is usually single in the thoracic or thoracolumbar region, involving 4 to 6 segments, and most characteristically has a severe amount of rotation. You can also find vertebral scalloping that is more than 3 millimeters in the thoracic spine and more than 4 millimeters in the lumbar spine, and this is associated with either dural ectasia or the presence of a neurofibroma. You can find repenciling, and this correlates well with progression of the scoliotic deformity. If you find more than 3 pencil ribs, this is an indicator for curve progression. You can also find spindling of the transverse processes, which is defined as loss of more than 50% of the TP height halfway between the tip and the vertebral body. You can also find wedging of the vertebral bodies either in the coronal or sagittal planes. You can find enlargement of the intervertebral foramen, which is defined as an increase in the height of the foramen by more than 1/3 of the height of an uninvolved foramen, either above or below, and this is usually associated with a dumbbell-shaped neurofibroma. You can find widening of the interpedicular distance compared to a normal level, either above or below. You can also find a paravertebral soft tissue mass, which is due to the presence of a neurofibroma in the concavity of the curve. And finally, and most importantly, the presence of slender dysplastic pedicles, particularly at the apex of the curve, and this is very important, especially if you plan to place pedicle screws. So what's the importance for finding these dystrophic changes? Well, the severity of the spinal deformity correlates with the number of dystrophic features. This publication found that the presence of 3 or more dystrophic features was highly predictive for the need for surgery, and the most significant individual predictors found were vertebral scalloping and the presence of dural ectasia. Treatment of patients with spinal deformities and NF type 1 needs meticulous planning. These are very complex patients and need a multidisciplinary approach. You have to maintain a comprehensive global picture of the patient, and please don't overlook the cervical spine. Why is that? Because cervical spine deformities are usually overlooked. We always focus on the thoracic or thoracolumbar deformities. These cervical spine deformities can result in pain or a kyphotic deformity, and this is very important for our anesthesia colleagues during intubation. Treatment of these cervical spine deformities usually incorporates a front and back procedure. The most commonly found deformities are that in the thoracolumbar area, and these dystrophic curves should not be braced. There is no role for bracing these deformities. The line of treatment depends on the severity of the curve and the age of the patient at presentation. If you find a curve of less than 20 degrees, it only needs observation. If it's an early onset scoliosis with a curve of 20 degrees or more, this requires growing instrumentation, and there are several types that can be used in these patients. If it's a late onset scoliosis, treatment depends on both the curve magnitude in the coronal and sagittal planes. So if the curve is from 20 to 40 degrees, but with a kyphus of less than 50 degrees, usually a posterior fixation and correction is required. If the curve is more than 40 degrees, you will usually need a front and back procedure. But if the kyphosis is more than 50 degrees, you will usually need a front and back procedure that will incorporate a vertebrectomy or a VCR. One of the earliest publications on surgical correction of spinal deformities in neurofibromatosis was published in 1979 by Dr. Wimper and his colleagues, who reviewed the results of treating 102 patients. of whom 80 had dystrophic changes, and those were instrumented using the Harrington instrumentation system. They had a high failure rate that reached 64% and recommended that anterior and posterior procedures are needed with kyphosis of more than 50 degrees. And then came the era of the Cottrell-Deboussay instrumentation, and the earliest report of that was by Dr. Holt and his colleagues in 1989. Their study included 5 patients that were instrumented by an all-hooks construct. However, 3 of these 5 patients showed a progression of their scoliosis despite the instrumentation and fusion. And then hybrid systems that incorporated both screws and hooks were used. This resulted in better correction of the scoliotic deformities, kyphosis, and apical vertebral rotation. In 2010, we published our own experience in surgical correction of severe dystrophic neurofibromatosis curves in 32 patients. Our patients had an average age of 14 years. 13 had the apex of the deformity in the thoracic area, 14 in the thoracolumbar, and we had 5 lumbar curves. Our patients were followed up for an average of 6.5 years. We did a front and back procedure that consisted of an anterior release via a thoracotomy or a thoracoabdominal approach, and we took out 2 discs on either side of the apex of the curve, and then had a second stage posterior instrumentation, correction, and fusion using a hybrid construct utilizing both translation and derotation techniques. We did aggressive facetectomies to release these curves. We gradually corrected these deformities and performed meticulous decortication with generous autografting. We used a wake-up test, and we braced these patients for an average of 3 months post-operatively. Our patients were divided into 2 groups, those with a kyphos of less than 45 degrees and those with a kyphosis of more than 45 degrees. We achieved good correction in the coronal plane in both groups, and in the sagittal plane we achieved again good correction in both groups. This is one example of a patient from our study, a 15-year-old female who had a scoliotic deformity of 81 degrees corrected down to 37 and a kyphosis of 73 degrees corrected down to 45. And these are her clinical photos pre-op and at the final follow-up. There are several complications and pitfalls that you can find in these patients. The first is excessive bleeding that can occur. You can find defects in the posterior elements, so be very careful during your exposure. Those patients have a poor bone quality, and this can lead to failure of instrumentation either intraoperatively or in the post-operative phase. They also have a high rate of pseudoarthrosis, so you have to generously graft these patients. And despite all of that, curve progression can occur even in the presence of solid fusion. Sometimes you may need a corpectomy and circumferential spinal fusion in severe curves, but be very careful This is a very demanding procedure and with a high rate of complications. According to this study, one of the patients had an immediate post-operative mortality. With the introduction of all screws constructs, this led to their use in patients with dystrophic curves. And according to this publication, the one-staged posterior pedicle screw approach was found safe and effective in dystrophic curves in NF1 patients. The results of using pedicle screws was compared to that of hybrid constructs, and the authors found that combined anterior release and fusion with posterior fusion using either a pedicle screw construct or a hybrid construct provided similar curve correction both in the sagittal and coronal planes. Sagittal correction was maintained with both constructs, but patients with posterior instrumentation using pedicle screw constructs had significantly less of correction in the coronal plane. How about patients with early onset scoliosis and neurofibromatosis? Well, you can use growing rods, but be very careful. There are several complications that occur in these patients, like proximal junctional kyphosis and metal failures. So spinal deformities in NF1 patients are a surgical challenge. Early intervention is recommended and leads to very good results, but you have to consider all planes of the deformity and be aware of the possible anatomical abnormalities. Close follow-up is required to detect and treat any complication. Thank you very much.
Thank you very much, Professor Ware. A very clear presentation, and it gives me great pleasure to introduce our next speaker, Dr. Maaz Al-Ghadir. Dr. Maaz is a spine and pediatric orthopedic consultant at the King Fahd Medical City, Saudi Arabia. And Dr. Maaz will deliver his talk on neuromuscular scoliosis. Dr. Maaz, اتفضل حضرتك.
السلام عليكم ورحمة الله. الصوت واضح؟
واضح.
تمام واضح.
First of all, I want to thank the organizing committee to give me this chance to join you and talk about neuromuscular scoliosis, and I will try to be as quick as I can. So can you go to the next slide, please? This is the main points that we will try to go through in our presentation. Next, please. So these are the main causes for neuromuscular scoliosis, the etiology. The most common that we see in our practice is cerebral palsy, and there are other peripheral neurological diseases like polymyelitis, like Duchenne muscular dystrophy. Next, please. The prevalence in cerebral palsy, 25% of patients with cerebral palsy, they have neuromuscular scoliosis. Now, this is different depending on the severity of the brain involvement. So in hemiplegic patients who are walker most of the time, the prevalence is about 5%, but in quadriplegic patients, it can go up to 75%. And the severity of the curve also increase as the severity of brain insult is more. And this is the prevalence in other diseases, but of course, because we have more cerebral palsy cases, most of our cases are due to cerebral palsy. Next, please. And this is the typical curve. It's a C shape rather than idiopathic scoliosis, which is an S shape, except in patients with hemiplegia, because many of these patients, they present with curves that look like idiopathic curves, because most of them are walker. But in patients with quadriplegia and the severe involvement, it's usually an S shape. Next, please. It's important to obliterate pelvic obliquity as a factor or as a reason for scoliosis before we go to surgery, because in some patients surgery might not be needed if the reason is pelvic obliquity due to tight hip adductors, and we will show how we can do that. But most of the cases have both genuine pelvic obliquity and genuine neuromuscular scoliosis, and usually both of them need to be addressed. Next. So as we all know, with compression, the pedicles are smaller, and with distraction, the pedicles are bigger in the concave, on the convex side. Next, please. Next. So this is the cascade of the problem and how to progress. So the main reason is the muscle imbalance, which lead to abnormal loading on the spine, and then lead to asymmetrical growth of the vertebrae and neuromuscular scoliosis. Next. Okay. Next. There are many classifications for neuromuscular scoliosis. I like Akbarnia classification because it's a practical one. It's basically two groups, group 1 and group 2. Group 1 is A and B, where there is minimal or no pelvic obliquity, whether it's an S shape or where there is a well balance of the trunk, or it's not balanced, but there is no pelvic obliquity. These are usually walker patients. And group 2, where the severity is worse with severe pelvic obliquity, usually they are non-walker, and usually they need the fixation to the pelvis. Next. Next. So it's important clinically to decide if there's truncal shift, which is usually the reason, which is usually there because it's decompensated curve, and in many patients there is upper kyphotic deformity that we need to be aware of in the lateral X-ray, because it's important to go proximally as much as possible and to try to avoid junctional kyphosis. We will show how to assess pelvic obliquity and contracture of lower limbs. Many of these have severe contracture of lower limbs, and this might be a problem when positioning the patient prone on the table, on the Jackson frame, because sometimes because of the tight popliteal angle, the legs are up in the sky. So sometimes we need to address the soft tissue contracture before we do this. And it's important to see, as you can see in the picture, how flexible the curve is, to see how much correction you might be able to achieve. Next. This is the assessment of hip contracture. Next, please. This is how to assess pelvic obliquity. So you try to eliminate pelvic obliquity, and you see in the middle figure, you can see that the scoliosis was secondary to pelvic obliquity. So when you corrected it, the deformity in the spine disappeared. While in C, it's a genuine pelvic scoliosis, not related to something in the hip, which is usually tight hip adductors. Next. Next. So as we all know, these patients are challenging patients. Many of them have bad respiratory function, and of course they need an anesthetist to evaluate them, and most of them are high risk, most of them, unless they are walker like hemiplegic, for surgery. And nutrition is important. There are several parameters to examine that, like albumin. It's very important to assess. I always ask my fellows and residents in the clinic, when they want to talk to me about patient to book him for surgery, what's his weight? So I have this arbitrary number, which is about 20 kg. If the patient is less than 20 kg, I really become very hesitant to operate on him, and I refer him to nutrition. Unfortunately, their chance of improving the weight with the nutritionist is slow and painful, and in many occasions non-successful. But at least I do whatever I can do to get the weight around 25 or 30. Of course, that depends on the height of the patient, because most of them are small. Sometimes nasogastric tube is a good idea. Of course, we assess his lower limb function, like does he have bladder control? Is he a walker, non-walker? Poor nutrition predisposed to all complications that you might expect, from death post-op to prolonged intubation to tracheostomy. Next, please. So these are some predictors of problems post-op: high cup angle, FVC less than 40%, and older age. Next. So to assess pelvic obliquity radiographically, to decide whether we need to fix to the pelvis or not, the easiest way is to draw a line between the iliac crests and then a horizontal line and measure that angle, as you can see in the left most left side picture. And if the angle is more than 10 to 15, then most likely we need to fix that patient all the way to the pelvis. Next. Again, these are some indications for MRI. Rapid progression, and usually neuromuscular scoliosis have rapid progression of their curve. They don't respond well to braces. So in many cases there is a rapid progression and lumbar hyperlordosis. And when I will show you some cases that we've done at the end, and one of them showed this hyperlordosis of the lumbar spine, which is challenging intraoperatively. So next. Okay, now let's talk about management. It depends on several factors like the curve severity, the quality of life, and life expectancy of the patient, and the predicted complication rate, whether he can tolerate the surgery or not, and his general health, his weight, as we talked about. Next. Next, please. So if the cup angle is less than 20, we observe. If the cup angle is more than 20, we brace the patient. But I usually inform the family that braces are less successful than in idiopathic scoliosis. And the idea of braces, usually the TLSO in these patients, is to buy time. Many of them are really small, whether small in size or small and young in age. So usually I use brace to buy some time, a couple of years, and until the patient is a bit more tolerable for the surgery. Next. So if the patient is a walker, we need to have a balanced spine and prevent progression, improve pulmonary status, and prevent respiratory problem, like in idiopathic scoliosis. And in these patients, we usually try to avoid fixing the patient to the pelvis because there is minimal pelvic obliquity. In non-walker, it's maintaining a good seating position and facilitate care and sitting in the wheelchair, and this is important for his psychological status and for the caregiver and for feeding purposes. So it is important for even non-walker patients. Next. So now with screw fixation, as you all know, previously the idea was the main treatment was Galveston technique and sublaminar wire. Now basically, not a lot of people are doing that. At least in my practice, I'm not doing that. I'm doing screws for the whole spine. And with this strong fixation, the need for anterior fixation is close to zero. And in my practice, I've never needed to open a cerebral palsy patient or neuromuscular patient anteriorly, especially with their bad lung and respiratory function. So in these patients, you try to do it in one shot. Even the surgery, if the surgery is a bit long, you try to watch the blood loss and everything else and communicate well with the anesthetist. And then you try to make it in one stage if you can. Usually we go from T1 or T3 to all the way to the sacrum, and unless the pelvic obliquity is less than 10 to 15 degrees. I do use femoral traction with Gardner-Wells pen in severe cases, not in all the cases. And many of these cases are severe, and I don't I don't want you to misunderstand femoral traction. It's not a skeletal traction, it's only a skin traction. Because of the hustle of the skeletal traction. This is the only reason. Because sometimes the anesthetists spend several hours preparing these patients. Central line might take an hour, and the intubation is difficult. So I find that skin traction is quick, and it do most of the needed function of skeletal traction. Next. So these are the indications for pelvic fixation. The pelvic obliquity is more than 15 degrees. And when there's truncal decompensation, which is the case in many of the patients. So most of these patients who are quadriplegic, they have a truncal shift to the right or the left, depend on the convexity of the curve. So you draw a central vertical line and you decide where it's going from the C1. Next. So here you have neutral and you have positive. Next. 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 And that's the reason we don't fuse the pelvis in patient with MMC if they are walker, because they can lose the ability to walk. Next. Next, please. So what's the role of intraoperative monitoring on these cases? And that's a common question that we usually face. What I do is when there is no function at all in the lower limbs and no sensation, I don't bother communicating with my neurophysiology team. If there is some kind of movement and sensation, they enter with us and they try to see if they have any baseline that is, no matter how weak it is, that they can use as a baseline. Sometimes they can do that. Sometimes even if I have something clinical, they can't have anything. SSSP is more reliable because most of these patients are non-walker. Any loss of more than 50% intra-op is considered a positive loss due to insult. Next. Next. So this is a study that we did and we present last year, and we found that there is no role for intraoperative monitoring in patients with Friedreich ataxia. Next. You need to watch the blood loss in these patients and the chance of hypothermia and hypotension. You need good communication with the anesthetist during the procedure, whether the patient can tolerate that you continue the whole case or you need to cut in the middle. Next. These are common post-operative problems, and extubating the patient is a very important indication that the patient will do well. So I usually, because most of these patients cannot be sent to the ward or to the ICU extubated, most of them will go intubated after long procedure and bad lung. So I'm really eager to extubate them as quick as possible post-op. Next. These are some risk factors for complications. Next. So there are some pros and cons for pelvic fixation in these patients. The pros are good seating balance and improve pulmonary function because of the good seating balance and better quality of life. And the risk is that there is extra blood loss and longer surgical time. And this is one of the reasons why sometimes I don't put iliac screws and I go all the way to S1 and S2 just to buy the patient some time, because putting iliac screws sometimes in thin patients when their pelvis is really thin and small, you don't want to miss your chance and you need O-arm. And O-arm, as you all know, preparation for O-arm will take at least 45 minutes, so it's hectic. You need to be careful that the head of the iliac screw is not prominent, as this might predispose to pressure ulcer. And I will just show one tip that I use to avoid this. Next, please. These are different methods for pelvic fixation. The best one is the maximum width, the third from the right, the upper right one, because you have screws ideally on L5 and sacroiliac screws and iliac screws. And you can see other fixation types. Of course, the Galveston was the standard treatment long time ago. Next. So in A, you can see the sublaminar wire with the Galveston, and then these are different fixation types. So in B, you can see screws in S1 and ilium with iliac connectors. In C, you can see fixation to the ilium without S1. And in D, fixation to the sacrum without iliac screws. Next. So fixation, it's a mechanical construct, and you can have failure anywhere, whether the set screw disengage from the rod, whether the connector, the iliac connector disconnect from the rod or from the iliac screws, or if the screw is loosened around the bone due to infection or due to any other reason. Next. This is our study that we published last year. So we studied 43 patients with that average age. Most of them were girls, and the average follow-up is not very great. It's only 2 years for now. Next. Cerebral palsy, as in all our practice, I believe, is the most common reason. Next. And this is the main cup angle pre-op. We had some cases worse, some cases milder, and the post-op correction was up to 30 degrees. There was kyphosis, and it was corrected and addressed post-operatively. Next. And these are our complications. So the blood loss is more than what we should aim for, but this is what we had. And we had wound complication, most of it related to bad nutrition and infection. And I will show you some cases where the screw was moved and how did we fix it. Next. So now we will go quickly through some cases. This is an 18-year-old patient with cerebral palsy, and this is her view pre-op, and we fix it with iliac screws. Now, I told you guys that I will talk about how to make the fixation more strong and chances for implant failure less. What I usually do is I don't use iliac connector. I started to do this long time ago, and then I quit. So what I do is I make sure that when I put the iliac screw, I make sure that the head of the iliac screw goes with L5 or S1 if I have S1 in the main trajectory. So that when I put the rod, it's going with them. And I also make sure that it's not prominent. And to do this, the only trick that I do is I take a real good bite from from the iliac spine. So I dig a big hole in the iliac spine, posterior iliac spine, and I make sure that, that when I insert the screw head before even putting the rod, that the screw is not prominent. It's going with the iliac bone itself, and it's in the same trajectory of the rest of the screws, so that I will avoid the need of iliac connector, and now you will have less chance for failure. This is what I do. Next. This is another patient. Where the pre-op view is there, and we achieved good correction. You can see the truncal shift to the right, how bad it is. I inserted iliac screws in this patient, and this is the correction. Next. Next, please. So this patient is non-walker, as you can see, and we had to fix her all the way to the pelvis. And this is one of my old cases, because I had to, I can tell, I don't remember the case, but I can tell from the iliac connector. In these cases, I do traction, and I put more traction in the concave side. So the traction is not symmetrical in the leg. So if I have 10 on the right side, for example, I will have 20 pounds on the left side. And I rarely do any pedicle substructure osteotomy in these cases. What I do is I do extensive Ponte osteotomy, and before I do the osteotomy, I'll tell the anesthetist that I'll proceed with the osteotomy so that he will be ready with the blood. And usually I achieve really good correction. One thing I'd like to tell you is that most of these patients have, many of these patients have dislocation of the hip in the concave side, and usually it's not bothering them a lot due to pelvic obliquity. When you correct this the deformity, and you correct the pelvic obliquity, the prominence of the dislocated hip is more apparent. So it's really important, and there is also a debate between us and the orthopedic whom to proceed first, and usually I proceed first. I don't bother, but I always tell the family that the dislocation is there. It will not get worse, but it will look worse due to the correction. Now, when the family are aware of this pre-op, they are happy post-op, and they are not worried. If they discover this post-op, and then I will tell them, then they might think that I'm just covering for a mistake. Next. Next. This patient had a prominence of the iliac screws, and we had to remove it, and the patient did well after that with no pressure ulcer. Next. This is another patient, and we fixed her to the pelvis. If you notice, I'm not sure how clear it is, but this patient is obese. In the lateral view pre-op, you can see that the patient is a bit obese, and you see the lumbar kyphosis, which is a tough issue, but doing Ponte osteotomy will help a lot in correcting it. Now, this patient, despite that I went to the LEM, we had a complications with her, and you can see it in the next slide. Next, please. This is not a cerebral palsy patient. This is a patient. This patient had a road traffic accident and was paraplegic, and you can see that there's screw loosening in more than one area, all in the left side, and it was addressed. And when we opened, we told the family that there is a chance of infection, but luckily it was a mechanical failure or lethal, so there was no infection, and we fixed it again, and we used wider screws, and we inserted more bone graft, and the patient did well until now. Next. This is another patient, and despite he was 18 and he has a bad curve, I'm really happy with his correction. And you can see that I did not need to go all the way to the LEM. I went to S1 and S2 and call it a day. Next. Another patient. Next. You can see the improvement in the truncal shift. Next, please. This is a tough case. We had to do two-stage, and in two-stage, I did not go anterior and posterior. So what I do is I go and insert most of the screws. Sometimes I need O-arm. In this case, I didn't need O-arm, but I make the O-arm in such cases available standby. I do as much osteotomy as possible, generous Conte osteotomy. And then in doing this, usually the patient will be on the table for several hours and he will bleed a lot. And usually we have some issues with signal changes and hypotension. So both the anesthetist and the neurophysiologist are on the same page on this patient that it's better to give the cord chance to recovery. So I do the first stage, and in the next stage, also posterior from the same wound, I insert what is left for me, and I put the rods. And this week, I put the patient on traction. So skin traction in the lower limbs and pins in the skull. And I struggle with him during that week because he complained and he cannot walk and he cannot move and he's tied to the bed. But I put him in traction, trying to make the spine as flexible as possible. Next, please. So you can see in the pre-op, in the lateral view, the proximal kyphosis. And it's really important to address that. Now, this is a whole topic by itself. By not insulting the soft tissue and the ligaments proximally as much as possible, by bringing the rod to the last screws without any tension. So I always tell my fellow and resident, in the last screw, bring the incito bender and bring the rod to the screw. I don't want any tension on these proximal screws because I don't want them to move after a couple of days. And some people believe in hook fixation, as it might decrease the chance of junctional kyphosis post-op. Next. I think this is the last case. I'm sorry if I'm late. And you can see the kyphosis, it improved post-operatively, and there is no iliac screw fixation. Next. Next, please. Okay, next. This is the truncal shift, just to show the improvement in the truncal shift. Next. Again, next. Keep going, sir. Keep going. So neuromuscular scoliosis are much more challenging than idiopathic, and I hope that I shared with you my challenges and complication, and I hope that was useful to everyone. Thank you very much.
Thank you very much, Dr. Muaz, for a very nice presentation and sharing with us such difficult cases. Our next speaker will be our dear friend, Dr. Wael Al-Qasim from Arbil, Iraq. Dr. Wael is a spine consultant, and he was going to talk about the cervical, upper cervical deformity. Please, Wael.
Hello, Sharif. Hi, how are you? Thank you for this invitation again, and I'm going to start my talk about the upper cervical deformity. First, we will start with the anatomy about this upper cervical. All we know that the craniocervical, the upper cervical, it's a unique anatomy. I'm going to focus this talk about the C2. Exactly, I mean the pathological deformity that affects the C2. So here there is a complex of ligament, of facet joint, nerves, vertebral arteries, and all it's a very complex anatomy. Usually we need to go for CAD overlaps to read a lot to get the knowledge about this anatomy. So the upper cervical, it's always difficult. the anatomy here, it's always make the issues it's more difficult. And if we will look about the anterior approach in this area, it's full of risks. And even we have normal anatomical variations in this area. Many studies shows that the anatomical variation in this area, it's even much more anywhere else. And plus the instrumentation in this place usually had some more training. So what we face a lot of congenital anomalies, tumors, infections, trauma, etc. All things that we face in this area. I'm going to give an examples case sharing about the congenital and the tumors. First, I'm going to start with this case with the Moricchio syndrome. This is Moricchio syndrome, a 3-year-old, and he came with sent by pediatric with progressive paraparesis. And in the MRIs, you can see that how is it the C1, C2, there is clear compression in the spinal cord. It's quite clear in the T2, and the patient with dynamic X-ray, there is very mild instability, not that much unstable. I mean, regarding the C1, C2. So if we saw the CT angio, which is always I'm doing CT angio for all these patients, we can find the posterior arc of the C1 is absent. The interior arc of the C1 is absent. This is usually what we have during the growing spine, the ossifications of the lateral mass of the C1, usually it's absent. So there is kind of pressure on the spinal cord, even there is no bony structure yet, but it's a ligament one. And this is what we face in Moricchio. You can see here how the posterior part of the C1 is an absence. And what we did usually I used hooks for this lateral C1, both of them, push it out posteriorly, did the reduction. And here we can see that how the CT scan shows the distance between or the C1, C2, very good reduction, even in the axial one. And here you can see the hooks, how it's firmly grabbed the lateral C1. I used the graph. This is the patient walking very well and not any deficient. If I will want to move to something else with the C2, C3 kyphotic, it's a localized kyphotic. There was no history of trauma in this case, but I think it's traumatic. It looked like traumatic, but the patient, he is a doctor and he didn't mention any kind of trauma. If in the CT scan, I could recognize that even there is a locked facet in the left one. If you can see that there's locked facet plus, you can see that there is a fusion in this. So it might be traumatic. Also, it might be a congenital one. So what you can see, this is the fusion part. And what we did, we start first posteriorly. We insert the screws, and then without putting the rod, went anteriorly. We do the cage reduction, and this is the final, which with good alignment for the C2, C3. What about arthritis? Always we saw the patient with arthritis with also C1, C2, kyphotic dislocation, deformity. With the panas, you can easily recognize the panas, which is making the pressure on the spinal cord, and this is it's alone, it's a sign of instability. So again, always CT angio, 3D reconstruction. We can find a lot of anomalies here. We can see that the high riding of the vertebral artery, that means you cannot put C2 pedicles or barbs, or even C1, C2 transarticular screws. Again, in the same patient, we have the ostius posticus one. That means the vertebral artery is coming inside a bony structural above the ring of the C1, and we have to be careful during the preparation. What I did, I went posteriorly. I did fixation. I did the laminoplasty. You can recognize on the right side the mesh that I did as extension to the ring of the C1. Especially, I couldn't achieve value 100% reduction. And if you notice also, I used the laminar screw. The laminar screw instead of the pedicle one in the left side where was the high riding vertebral artery. The laminar screw is very powerful one. It's very easy, and it's written in all the LO spine or publication, and it gives a very good reduction, similar to the pedicle or pars screws. This is the MRI for the patient 6 months after the surgery, and you can see that how the pus disappeared because of the fusion. I want to also assure about the CT angio. In every time, and this CT angio, you cannot get the result from the radiologist. You have to sit on the workstation you're on, and you have to read the CT yourself, section by sections in all areas, and to plan for the surgery. Again, I'm going to talk about the another kind of anomaly, which is the basilar invagination. I know this is somehow a little bit more for the neurosurgeon, but this is still a deformity of the neck. And here you can see that this is 40-year male with progressive numbness, sexual dysfunction, but there was no weakness. You can see how the odontoids make a pressure on the medullary cervical junction. And you can see even the odontoid, it's going up, or you can say the skull diving down. And you can see the distance between the C1 and odontoid is a bit more. And this is a surgical case, always again, CT angio, blind my surgery. This is a little bit tricky that you have to go with the osteotome in between what was C1, C2, and as here there's an assimilation of the C1, that means the C1 is fused to the condyle. So I have to do this location in this joint. And this is what I'm doing with this osteotome. And you can see here by the video that how I'm cracking the joint, open it, and after opening this, I'm going to put a graft. This is the pre-op and after the surgery, how I could bring the odontoid anteriorly and lower down. And this is the graft bilaterally in after I did the dislocation of the joint. Then I put iliac graft. There is a lot of surgeons who putting a cage. There is special cages are now in the market for the C1, C2 joint. Another anomaly again, also for the C2 or the upper cervical one, the os aves anomaly or os odontium. This is all a very huge number of anomalies. Again, we can see that there is no C1, and the hypertrophic odontoid went posteriorly, make a pressure on the spinal cord, and you can see even on the axial MRI on the right side that there is no any space for the cord. In the CT scan, you can see how it's going back, and very severe. This patient actually it came with a severe paralysis. And the surgery again, do the dislocation to the joint, bring it down. And again, I used the laminar because it's very difficult to me to do the C2 because of the vertebral arteries was high riding. And you can notice that how I took a very huge big iliac graft and put it in the craniocervical junction, just to be sure that the fusion will happen. This is patient always need a hollow vist for 6 months after the surgery. It was about kind of congenital anomaly. What about the tumors? Also, a lot of patients sometimes come with cervical tilt because of the tumors. I will go so fast with some cases. A woman about 45-year-old, history of hemangiopericytomas, metastasis to the liver, previous surgery 3 years or 4 years ago. And you can see the osteolytic lesion on the C2 and here in the CT scan. Again and again, I'm always doing the CT angio, looking very well. Here I saw that there is posteriorly variant vessels to the right side. As we are talking about metastasis, so it was a palliative procedure. So what I decided, I went to anteriorly transoral. I took a biopsy, and the transoral, I did a vertebroplasty. Vertebroplasty, it's very easy. Directly, we can found the C2 with the cement, and technically it's written in many textbooks. The patient directly pain-free after the vertebroplasty. One day, then the same night she went home and they are speaking other. This is in her native language. She said that it's very good. One more about a 15-year-old female came with tilt, painful tilt, MRI, CT scan, lesion in the C2. This is the cause of the deformity. Biopsy, it was a giant cell. So our strategy in the giant cell, correction of the tumors, and in the CT angio, there is a tilt. I have to correct also the tilt, and first went posteriorly, then I went an upper cervical approach. Upper cervical approach is totally different about the standard cervical, because there's a lot of anatomy here. Sublingual nerve, the upper laryngeal nerve, the gastric, the anatomy is full. I went it and resect all the tumor after anteriorly, and you can see how I put, this is iliac, and the patient did very well. And here, this is the CT scan after the surgery to be sure that everything is well. And this is how it was before the surgery. This is the anatomy. This is the submandibular gland, the superior nerve, the gastric muscle. It's a little bit more difficult, more minded how to reach, especially after you did posterior fusion. It's somehow difficult to go anteriorly because you cannot achieve a good flexion and extension to the neck. One more, it's painful neck tilt. You can see how the patient, and again, always do my study. This is the tumor on the CT scan. You can see how it's gone from posteriorly, took all the C2, which is osteolytic, and with the biopsy, it's a plasmacytoma. So the plasmacytoma, we know all that it is sensitive to the radiotherapy, and this is why we decided to do a palliative surgery again, and we start again from posterior. Then I went anteriorly about the same approach, upper cervical height, and I want all notice that how I customize the mesh. I put the ring of the C1 up and the tail down, and the C3, C4, I put a cage also. Then I put a blade, which is hold this tail. I don't want to go to the clivus, even just only C1 and C3. And this is how it looks after the surgery. And this is 1 year she sent me the X-ray, and she's doing very well, no deficit at all. Finally, this is the last case, 20-year female progressive quadriparesis, neck tilt, deformity, kyphotic again in the C2, very huge tumors discovered 3 years ago. The biopsy 2 times took, and it was histiocytosis. She received chemotherapy, radiotherapy, but now she is getting worse and worse. You can see that the MRI, it's the tumor came from the clivus to the C3, and which is very huge tumor. Here, what we are doing, it's another technique for this kind of do tracheostomy, transmandibular approach, and cut the trunk, infiltrate with the adrenaline, less bleeding. I sure in my CR that I could reach the clivus. Then I took a fibula graft, customized it, put it in, fixed in the from the clivus to the C5, Then I closed the transmandibular, went posteriorly next day, not on the same day, and I did craniocervical fixation, grafting, ensure always about the grafting, and this is how it looks, the final X-ray after the surgery. Usually those patients have to remain on the tracheostomy more than 3 weeks. They have to learn how to speak. Dysphonia, it's a common cause. Infection, it's very common cause. But it's better than that. Let the tumor make a pressure on the spinal cord and deficits happen. Thank you very much.
Thank you very much, Dr. Wael, for your very nice presentation and such challenging cases. Our next speaker will be Dr. Ahmed Shawqi. So Ahmed Shawqi is a consultant spine surgery in Erfurt, Germany, and he has his presentation and is recorded. Mustafa?
Good evening, my dear colleagues. It's my pleasure to participate in this outstanding Scoliosis Week 2021. First of all, I would like to thank Professor Yusuf Al-Hawari, Professor Muhammad Khattab, and Dr. Sharif Al-Ghamri for the kind invitation. I will speak about adolescent congenital kyphoscoliosis. And with adolescent congenital kyphoscoliosis, we mean congenital scoliosis or kyphosis that first present during adolescence. These are coronal plane curvatures secondary to an anomalous congenital vertebral defect that is present at birth. These are commonly kyphoscoliotic deformities. Sometimes they are part of a syndrome, and up to 60% of these patients may have malformations of other organ systems. Regarding classification, either we have failure of formation, failure of segmentation, or combined. A rigid vertebra may be fully segmented, partially segmented, or non-segmented. And furthermore, a hemivertebra can be subclassified into incarcerated or non-incarcerated according to the presence or absence of a disc space above, below, or both of these vertebrae. The clinical assessment must include craniofacial malformations, Klebel-Feil web neck, cardiac malformations, and urinary malformations. Regarding the diagnostic workup, we have the standard radiographs, which should include whole spine radiographs, functional views, flexion extension, side bending, or traction views, and these are very important, especially for the secondary curves, because with late presentations, we commonly see structural secondary curves with these congenital anomalies, which should be included in your correction procedure. You should have cervical spine radiographs, spot views of the malformation, and chest radiographs. These are examples of the diagnostic workup. We have to the left side, we have the standing view, we have bending to the left and then bending to the right, and we have the whole spine sagittal radiograph. And you can see here the curve is a rigid curve, it is a congenital curve, and as we mentioned, it's commonly kyphoscoliotic deformity. It's not only a hemivertebra but also a hemi and a rigid vertebra. Also, the diagnostic workup should include serial radiographs which should always be compared with the initial radiographs, and measurements should include Cobb angle of the whole curve, Cobb angle of the angular deformity, Cobb angle of any compensatory curves, assessment of vertebral rotation, and rib vertebral angle. MRI is a must in these patients, as they are commonly associated with intraspinal anomalies like C-rings, tethered cord, or Chiari malformations. Also, CT is a must in these patients with 3D reconstructions to clearly evaluate the deformity and also to plan your surgical corrective procedure. This is example of the MRI of the previously presented radiographs. The same patient, she's 14 years old girl, and you can see the cord is extremely adherent and stretched on the concave side of the deformity. And on the axial cuts, actually the first and second to the left are coronal cuts, and the axial cuts to the right, you can see the cord is extremely adherent to the pedicles on the concave side, and these screws are extremely difficult and extremely dangerous too. Actually, all of these cases must be done under intraoperative somatosensory and motor neuromonitoring. Regarding the natural history of congenital scoliosis, many reports mention the natural history of kyphotic and scoliotic deformities. This is an old publication by McMaster et al., and they mentioned that it's possible to anticipate the course of the congenital scoliosis if the type of vertebral anomaly and its site are known. And you can see here we have the highest curves are presented between 12 and 14 years old. Failure to appreciate the potential for deterioration and hence missing the opportunity to intervene and modify the growth of these anomalies can lead to potentially catastrophic neurologic complications which otherwise may be preventable. This is also an old publication by Winter and Moore, and they stratified the risk of curve progression from the greatest risk to the lowest risk, and as we see, the greatest risk when you have a unilateral unsegmented bar with contralateral hemivertebra with a risk of about 10 degrees progression per year, and that's to say if you have a 10 years old patient you have about 100 degrees curve, and the lowest risk of progression for a block vertebra. The challenges with these lately presented cases include many problems like tilting of the head, unbalanced shoulder, decompensation of the trunk, pelvic obliquity, formation of large secondary structural curves. And if you treat these patients early, these curves are not structural. You can avoid fusion of these curves. But if they present late, you usually need to long instrument and fuse these curves. As we mentioned, curves are often rigid, complex, and multiplanar. Compensatory curves commonly turn structural. Patients commonly present with neurological complications with angular curves, and it is a very difficult complex correction with 3-column osteotomies like PSO, VSR, and spinal column resection. Regarding management of these curves, the prophylactic procedures and the cross-friendly procedures have no role in these patients. You commonly need 3-column osteotomies like PSO, VSR, or spinal column resection, and always consider and manage intramedullary anomalies accordingly. Many modifications of these 3-column osteotomies were published, like this one. For hemivertebra, you can use like a modified PSO, unilateral PSO, and these colleagues mentioned they have less blood loss and less operative time. Also, it is very difficult to achieve full correction in these cases, and that's why this is also another publication. They used all pedicle screw technique with multiple chevron osteotomies and multiple concave side rib osteotomies, and they mentioned also a good outcome. The most commonly procedures used in these patients are vertebral column resection and spinal column resection. These can be done anteriorly, posteriorly, or combined. I'd like to share this recent publication published from Us University. Actually, this technique was first described by my dear mentor, Professor Muhammad al-Mishtawi, and we published this technique with our dear colleague, Dr. Bilal al-Nadi. He inserted anterior screws adjacent to the apex of the deformity. These usually help to directly distract the anterior column. I would say controlled distraction of the anterior column after resection of the kyphus and decompression of the spinal cord. And we reported about 14 cases with excellent long-term outcome. Actually, these procedures, as I mentioned, are complex and dangerous, and they are commonly associated with complications, especially if you have combined intraspinal anomaly. I will present few cases. This is a female patient, 17 years old. Actually, this is a case of Professor Muhammad al-Mishtawi. She was presented with this more than 100-degree congenital kyphotic curve, and he used the procedure of inserting anterior screws through the posterior approach with vertebral column resection of the kyphus. Here, 2 vertebrae with long construct, and you can see here are the follow-up x-rays after 2 years with a curve of about 35 degrees. This is one of my patients. He's a young boy, 13 years old, with a congenital widget vertebra. It's also kyphoscoliotic deformity, but the main problem is the lumbar kyphosis. I operated him with posterior vertebral column resection and this long construct, and this is his sagittal profile post-operatively. Another patient with about 100-degree kyphotic deformity at the proximal thoracic spine. I treated him with posterior vertebral column resection and long construct, and this is his immediate post-operative profile. And actually, it was a long discussion to long instrument this patient to the C-spine or to stop at T1, and I decided to stop at C7, and this is his curve. This is a young female patient, 14 years old, presented with spastic gait and spastic paraparesis. She was unable to walk directly before the surgery, and I treated her with, these are the MRI of the patient. I treated her with posterior column resection and long correction. My take-home message: identification of curves at risk is crucial to prevent catastrophic complications. Neglected curves are complex, rigid, and necessitates complex corrective procedures. Intramedullary anomalies should be considered and addressed. No role of prophylactic surgical procedures and cost-friendly procedures in neglected cases. Again, many thanks Professor Yusri Al-Hawari, Professor Muhammad Hattab, and Dr. Sharif Al-Ghamri for the kind invitation. Thank you very much and goodbye.
Thank you very much, Dr. Ahmed, for your very nice presentation. I encourage all these to submit their questions in the Q&A box, and they will be answered by the panelists at the end of the session. Our next speaker is Dr. Muhammad Awad. Dr. Awad is Professor of Neurosurgery at Ain Shams University, Cairo, and he will present about the cervical malalignment. Dr. Muhammad. Yes, hi, Dr. Muhammad.
Dr. Awad, you are muted. Kindly unmute
You are
yourself.
muted, Dr. Muhammad.
Hello, السلام عليكم.
أي اتفضل، صوتك مسموع. Yes.
Can you hear me?
Yes, we can hear you.
Okay, I start screen sharing. Huh?
Yes, please.
Can you see my screen as well?
Yes, very clear.
Thank you. I'd like to thank Dr. Khattab first for the technical support he gave to me because I have a serious issue in my presentation. Initially, I'd like to thank Dr. Sharif Al-Tani, Dr. Yusri Hawari for allowing me to be with you in this well appreciated, repeatedly successful meeting. Thanks to all my colleagues who presented before my presentation. I really enjoyed the presentation so far. My talk today will be a case study for cervical malalignment. I'll try to be so comprehensive. I have no disclosures. But some of the material presented in my presentation are free online data. So the term global spine alignment is a very important term when we are managing patients with cervical, with spine disorders, either traumatic or degenerative, because we have to think about the patient as one piece. We don't look to regions only. We don't correct the cervical spine alone or the dorsal spine alone or the lumbar spine alone. We have to correct in relation to the whole spine. So the global spine alignment and the assessment for patient is very crucial. As we know that the surgical vertical axis is the term used for assessment of this the spine alignment, and there is different regional vertical sagittal assessment for each part. We can depend mainly on the COPS angle for determining of the thoracic kyphosis and as well as the cervical lordosis and lumbar lordosis as well. And the relation between the three angles will calculate the sagittal vertical axis for the patient. And we have to keep this in mind when we are performing any surgical intervention. And again, we need to know the contribution of the pelvic parameters and the knee joints for keeping the sagittal vertical axis. And I think the people with the orthopedic background, they are very good in consideration of this issue. For the topic today, for the cervical malalignment issues, we have to know the normal cervical curvature and how to assess it. There are many ways to assess the cervical lordosis, but mainly we depend on the COPS angle, which is from the lower border of C2 vertebra to the upper border of C7, and some people consider it to the lower border of C6 because of the more constant position of the C6 vertebra. However, there are many other techniques like the Harrison stress lines and the multiple Jackson physiological stress lines and all, but they are not familiar for common practice. The COPS angle, which you can see in the letter A here, is commonly used. Again, we have to think about the alignment of the cranium on the cervical spine. And we have some parameters, as we can see here, to determine the orbitomeatal lines of how we maintain the frontal horizontal gaze. And this is again very important, and it might be affecting our plan of surgery. And we have to keep in mind that we don't keep the cervical lordosis only, but we have to keep the cranium balanced as well. And we do pre-operative assessment how the correction we are going to do will affect the horizontal gaze mainly. And indirectly keeping a proper alignment of the skull and keeping the epicenter of the skull in the normal state is very important to prevent the stress loads on the screws, and also to maintain the function of the cervical spine, which is mainly to transmit the load of the head to the thoracic spine, as well as keeping the horizontal gaze. It's very important to keep the horizontal gaze of the patients. So I will skip some x-rays. This is other parameters to show the importance of the relationship between the cervical spine alignment and the T1 vertebra. And again, there is some parameters we have to look at when we look for the cervical lordosis and the relation between the cervical alignment and the dorsal alignment, as my colleague presented in his last case with the cervicothoracic kyphosis, and how the correction in the thoracic level can modulate the cervical alignment. And again, we do some dorsal osteotomies to correct the cervical malalignment. Not necessary to work on the cervical spine itself, but working on the dorsal spine and making some correction in the thoracic spine will eventually or indirectly will correct the cervical parameters. So in general, when we do surgeries, we have to look for decompression of the neural foramina, restoration of the normal cervical alignment to keep the subaxial lordosis Cook's angle around 15, to make the sagittal vertical axis less than 40 millimeters, and to maintain the chin brow vertical axis between -20 to +20, and this is very important for the horizontal gaze. I'd like to share with you one of the cases. What was the complaint is mainly cervical malalignment in one patient with cervical cord injury following RTA, ended up by cervical kyphoscoliosis. And this patient was initially operated by anterior decompression and fixation. As we can see here, this is the initial before the first surgery, before the time the patient was presented to us. We can see locked facet, we can see subluxation, but we can see the total cervical alignment was maintained. But this patient, the decision of the first surgeon was to do anterior only surgery for correction of the anomalies. And of course, we know we have a lot of possibilities in these cases. We need to do reduction, we may do anterior decompression, posterior decompression, or 360, or some people will do nothing because the patient is quadriplegic. So when the patient presented to us, he was in ICU on mechanical ventilation, tracheostomized 4 months after the primary intervention. He has the following problem. He has deformity, he has myelopathy, he has visual gaze problem, he has feeding problem, he has speech problems also as well. For the cervical spine, this patient was complaining from abnormal head position, and he cannot maintain the horizontal gaze because the epicenter of the skull was changed, and we discussed this already. So when we decide to correct this thing, we have to think about what anomaly has been already preserved. We need to decompress again, and if this decompression will be valuable or only to allow reduction of the deformity, we have to preserve the motion, and if the functional segment, we have to preserve it, we need to do fixation and we get collateral benefits. So again, this patient was presented 4 months after surgery, has progressive lateral kyphosis. He was tracheostomized, quadriplegic, on inotropes, ventilated. He has no bed sores, and he was fully conscious. And this patient are the result of intensive good ICU care. We end up by seeing these kind of patients. They don't die from the other collateral complications. And this was the end after 4 months. This is the plain X-ray for the patient. This is a sagittal reconstruction. As we can see, there is malalignment of the cervical spine. There is lateral scoliosis, and we can expect that there is abnormal posturing. So this patient is quadriplegic. What do you think we need to do for him? When we look from the patient perspective, he is fully conscious patient. He has to communicate even by eyes, even by talking, and he need to be fed. And this patient in this kind of position, you cannot feed him properly. The patient has abnormal gaze because he has eccentric gaze fixation. Apart from the abnormal posturing of the neck, the care of the patient will be difficult. So when we treat such cases, we have to review what are the benefits and the possible risks and what the targets from doing our intervention. Especially this patient is quadriplegic, there is no hope of walking again. But again, you need to comfortable this fully conscious patient. Every 1 second, he is only dependent on the head and neck. And of course, there is a lot of literature about the cervical deformity, how we evaluate and how to classify, and how to make this evaluation helpful in surgical planning. So for this patient, we either do nothing, or because we have less expected benefits, and I have to have very clear intervention goal. And of course, there is medical issues. The family are asking why this happened to this patient. How can we prevent this from happening in the future for after second intervention? Can this harm the patient in any way? How we can correct? And again, we need to correct. So the family insists to correct. And again, from the patient perspective, you need to help this patient. He cannot look at you properly. He cannot be fed properly. He has discomfort with his gaze. But again, this is very risky procedure. So we had to do something to help this patient to make his miserable scenario less miserable. So for surgery for this kind of patient, we have many challenges. Challenges of the health system, challenges for anesthesia, if you have the proper equipment, challenges of the surgery itself, and again, the expectations of the patient and his family and you as a doctor. The medical challenges are the anesthetic challenges. He is patient dependent on inotropes and he is unstable hemodynamically. There is possibility of infection because of the presence of tracheostomy and the long recumbency, already patient tracheostomized. This is all the fracture, and there is effusion mass that will not be easily to be destabilized again. The hardware problems, and again, how you will align the deformity. So first, we started the surgery by putting the patient on traction, and we tried to close the tracheostomy so the saliva will not be coming on the surgery site. And as we can see, it's a lot of surgical issues has been done from the anesthetic point of view to make this patient under sleep. And this is after closure of tracheostomy. And this is a planned new surgical incision to approach this. Usually we approach the cervical spine through a transverse incision, but for this case, I prefer to make longitudinal incision to have a good exposure. And of course, we removed the old hardware, which was loose, and we can have a long discussion why this happened to this patient. And this is not the issue of this talk. And again, we removed everything and we complete the corpectomy. We removed the corpectomy. Then we closed the skin for this stage. Then at the same site, we flip the patient to the prone position, aiming again, as I said, to remove the calcific or the ossified or to do posterior decompression and remove the subluxated loop facets and cut the muscles which somehow become ossified because of the that previous surgery. And we managed to do the posterior decompression, and we put some screws in the lateral mass as we could. But we did not finalize because we did not make the anterior reconstruction. And we hope that if we put rods at that level, we will not be able to get more reduction or more alignment. And again, we flip the patient and we put some weight this time to maintain the cervical alignment as possible. So correct it in the sagittal and the coronal plane, and we put a reconstructive mesh and we fix it. Then we flip the patient for the first time for the lateral mass and putting some bone graft. It's a 10 hours job, intensive post-operative care for that patient. And we managed to change this looking on the right side to the left side. It may not be 100% correction, but again, we managed to have a good cervical alignment, which achieved to the patient perfect horizontal gaze, perfect feeding issues, and we realigned for some degree the epicenter of the head to be neutral, so preventing more stresses on the hardware, preventing in the future recurrence of this issue. As we said, we changed a worse scenario to a less worse scenario, but the take-home messages are cervical alignment is part of the global spine alignment. Cervical alignment is important for equal head load transmission and horizontal gaze. Proper surgical planning for target goals is important, and the multiple parameters are involved in these issues, and we have to keep it in mind while we are dealing with these patients. Thank you, everyone. I'm welcome to have any questions. Thanks to Dr. Sharif Al-Ghitani, Dr. Muhammad Khattab, and all the faculty of Scoliosis Week, and I'm really honored to be part of this activity. Thank you.
Thank you so much, Professor Awad, for your presentation, and we'll keep the discussion till the end. And I encourage the attendees, if any questions or comments, please write it in questions and answer box, and we'll answer it and look after all your inquiries at the end of this webinar. The next speaker will be Dr. Yahya El-Brompoli, my dear friend and colleague from Zagazig University. He will cover the congenital kyphosis, what to do and how to manage. Dr. Yahya, تفضل.
Good afternoon, everyone. I'm Yahya El-Brompoli. I'll be presenting a small talk about congenital kyphosis. So to define it, beginning, it's an abnormally excessive forward curvature of the spine in the sagittal plane with a posterior convexity due to a congenital anomaly of the vertebral column. Congenital kyphosis is usually angular, progressive, and as there is a gross imbalance between the anterior and posterior portions of the abnormal region. So it's way far less common than congenital scoliosis. However, it is progressive without surgical intervention, and it is potentially more serious due to the high risk of neurologic deterioration, either from the deformity itself or from the corrective surgery. So there is the regular classification for congenital anomalies of the spine, which is failure of formation or failure of segmentation or mixed deformity. And there is a specific classification for congenital kyphosis. Type 1 is an anterior failure of vertebral body formation. This is the most common, and usually it causes a severe rigid angular deformity. We have type 2, which is an anterior failure of segmentation, and this is caused either by an anterior or an anterolateral bar. And these usually have a smooth kyphosis and usually involves multiple or several segments. And there is type 3, which is a combination of both. This is the least one of them, and it is the highest risk of progression. There is another classification, which is saying type 1, and when there is a correlation between the anterior part and the posterior part, and type 2 or type B, when there is a mismatch or discordance between the anterior and posterior part. And I'll show you that this CT scan, if you look at the L1 vertebra, hemivertebra, you will find that the L1 vertebra anteriorly is correlated with the hemivertebra posteriorly. So this is considered type 1, type A. The other one, on T11, you will see that the anterior hemivertebra is correlated with a fully formed posterior elements posteriorly. So this is a type B or discordant. And the surgeon should be very cautious and make sure that he knows whether this is a mismatch or not before doing surgery. Otherwise, you will be lost intraoperatively. In severe congenital deformity, there is high possibility for neurologic deficit due to the compromisation of blood supply by possibly 3 factors. 1, elongation and compression of the longitudinal arteries with kinking or stretching of the sulcal arteries of the spinal cord. 2, instability causing microcirculatory perfusion defects. Or 3, a congenital deficient segmental body supply at the level of the deformity. So there is neural impairment that will cause instability and increase the deformity, that will induce macromotion and insufficiency of perfusion, that will induce another neurologic impairment, and the vicious cycle will go on. So if you have a patient with neurologic deficit and congenital kyphosis, laminectomy or decompression alone is absolutely contraindicated, because it will not help the problem, because the compression is coming from anterior, not posterior, and will increase the instability. And preoperative traction is very debatable, and you should be very cautious doing that in a congenital kyphotic patient. There are high incidence of associated anomalies. They are 40% of neural axis abnormalities, 30% of genitourinary, and 20% of cardiac anomalies. So if you have a patient with congenital anomaly of the spine, always look for those 3. Radiological measurements, you need to know your local kyphotic angle, and the most important thing is to get the sagittal index, which is the kyphotic deformity at that area minus the normal contour at that area. So you get your sagittal index, which means that a kyphotic deformity at the thoracic spine is different, and the kyphotic deformity at the thoracolumbar is different to a kyphotic deformity in the lumbar region, because each one has its normal contour as well. So preoperative assessment, you need first a whole spine standing X-ray, AP and lateral. You need to know the local kyphosis of the deformity, the main thoracic kyphosis, the lumbar lordosis, all your spinopelvic parameters, your sagittal profile, either there is sagittal imbalance or not, and if there is any associated coronal deformity that you need to manage. Your flexibility X-rays here are hyperextension supine lateral X-rays over a bolster. It shows you how much the deformity is flexible. MRI is mandatory because you need to detect if there is any neural axis abnormalities or not, and you need to detect if there is a neural tissue compression. CT is very helpful. It helps you outline the abnormal anatomy, plan your anchorage point, and plan your resection or osteotomy. So you have a preoperative assessment checklist that you need to cover first. Then you think about your surgery. So what are the surgical goals that you're thinking about? First, recreate normal sagittal contours and sagittal balance. Number 2, decompress neural elements. Number 3, optimize changes for fusion, and do all that safely without harming the patient. So we have a lot of surgical choices, but they depend mainly on the age of the patient, type and size of the deformity, and neurological status. So I'll list some of them. So the first thing you could do is an early uninstrumented posterior fusion. If you have a very young patient and there is a very mild deformity, you can just do uninstrumented fusion, and that will help the deformity to stabilize or even correct a little bit over time. You could do a posterior instrumented fusion, especially in type 2 congenital kyphosis, when no major correction is needed and the patient is slightly bigger. And this is a very nice article that has been published this year out of Toronto. They did local fusion over the deformity and followed the patient for about 5 to 7 years, and they found that the angular deformity has decreased over time with posterior and instrumented fusion without attacking anterior elements. You could do either anterior and posterior excision and fusion if the deformity is more than 50 degrees and the child is still growing. So you go from anterior and do the section and use fusion and then posterior as well. If your patient is having a severe deformity with neurological deficit, it is mandatory that you do an anterior decompression. In that case, you'll do anterior decompression, do stop grafting, and then do a posterior fusion. or you could do an anterior instrumentation and start grafting alone from anterior without going posterior, and that if the patient is still young and there is no neurological deficit. Or you can do all posterior hemivertebral excision from the back, and that has gained a lot of popularity especially over the last decade. But you have to know that it is technically demanded because of you have to go anterior through posterior, and the anatomy here is very small and abnormal, so you need a lot of training about that. This is an example of a 6-year-old male patient that had a congenital kyphosis due to an hemivertebra on the thoracolumbar junction. This is an intraoperative photo showing the decompression and the wide area between the screws on the affected side. And this is after the correction. You can see now that the pedicle screws are almost on the same level. And this is a post-operative X-ray showing the correction. And if the patient is presenting late after skeletal maturity, you could do all from posterior and pick your osteotomy according to the correction needed, either from just facetectomy to posterior column fusion, posterior column osteotomy, pedicle structural osteotomy, extended PSO, 1-level VCR or 2-level VCR, according to the amount of correction needed. This is an example of a posteriorly done VCR in a congenital scoliosis. This is a nice article that has been published in 2019 out of Asyut University. It's a very nice where they do an anterior instrumentation through posterior approach, and this is one of their examples. It is quite amazing the correction they have achieved, and the anterior placed screws through posterior approach. It's a novel technique, and the results are very promising. So I have explained a lot of options through the to treat patients. So which one is the best and which one to choose? There is no one best solution for everyone, but I'll try to propose a treatment algorithm for congenital kyphosis. So first you look at the age of the patient, and then you distribute the patient according to the age to 3 groups, either young patients below 5 years of age, or more than 5 years of age, or skeletally mature patient. If you have a young patient, then you look at deformity. If you have a small deformity, you usually can get away only with posterior arthrodesis. But if it's a large deformity, then you have to do some kind of resection, either anterior posterior or all posterior resection. However, if the patient is more than 5 years of age, then you still have to need to do the resection, either anterior posterior or all posterior resection. If the patient is skeletally mature, then look at the neurological deficit. If the patient is neuro-free, you could possibly do all from posterior osteotomy. If the patient has any kind of neurologic deficit, then you need to do an anterior decompression first, augmented with the posterior fusion. This is a proposed treatment algorithm to help you in decision making. So the key points of my lecture: 1, congenital kyphosis is progressive. Early diagnosis and aggressive surgical treatment are mandatory for successful result. Early treatment minimizes the risks for surgery, especially in type 1 and 3. No effective conservative treatment for congenital kyphosis. Congenital kyphosis can lead to spinal cord compression and paraplegia. Surgical choice depends on the age, type, and neurological status of the patient. The proposed algorithm, as I said before, look at the age of the patient. Less than 5 years of age, then if the deformity is mild, then you can get away only with posterior arthrodesis. If it's more than 50, then you need to do some kind of resection, either anterior or posterior, or all posterior. If the patient is more than 5 years of age, then you need to do a resection as well. Skeletally mature patients, a little bit different. If they have neurological deficit, then you have to go anterior decompression. If not, then posterior osteotomy should be enough. Thank you.
Thank you so much, Dr. Yahya Al-Bromboli, for your nice presentation. And the next speaker will be a recorded recorded lecture for Professor Baron Lunar. Baron Lunar is an SRS leader. He is a dear friend of the Egyptian Scoliosis Society. Baron Lunar will deliver 2 talks. The first one, angular kyphosis, how to correction maneuvers. And the next one will be tips and tricks to reduce the complications while doing these osteotomies. Mustafa, can you please show us the recorded presentation. Thank you.
Good day, my friends and colleagues in Cairo, coming to you here from New York. And I'll speak to you today about angular kyphosis correction techniques. And I have quite a number of slides. And you heard my talk on neurological safety, and hopefully some of those points will be applied to this talk without repeating too much of it. And then we'll have a talk on osteotomies and limiting complications. So there's a fair amount of overlap and a lot of material to cover. These are my disclosures. So severe angular kyphosis generally is not that common, but when we do see them, there are common etiologies: post-tuberculosis, congenital, junctional kyphosis, and I'll show a number of cases that will at least illustrate some of these areas. Chin-on-chest deformity associated with ankylosing spondylitis, for example, fracture and neoplasm. The congenital classification is familiar to you all. Pott's disease and post-Pott's healing. A deformity appears like this, with patients sometimes experiencing neurological deficits in addition to progressive deformity, pain, and in some cases pulmonary dysfunction with severe deformity. There are different approaches, but really the vertebral column resection is the most useful. It's all posterior based, but historically there's been the palisading rib grafts that can be used, and in the hands of a surgeon without experience with PVCR may be the way to go. But vertebral column resection is the workhorse for this entity. It's safer to resect one vertebra, but at times the deformity is so severe that more than one have to be resected. We do posterior column osteotomies proximally and distally. It's important to use a temporizing rod so there's no translation of the spine and the spinal cord being stretched. It's important to use a cage as a fulcrum to obtain correction and to maintain spinal cord length. And that's illustrated here where a cantilever is performed. Now, we don't use a cantilever without a temporizing rod, so we do cantilever, but there has to be always a safety rod in place throughout. And you can use expandable cages or simple titanium mesh cage. This is the grade 5 Schwab SRS osteotomy with cage placed, and it permits 3-plane correction, but it's particularly useful in kyphosis correction. Here's the classification. Again, VCR single level is 5, and VCR more than one level is 6. Keeping the spinal cord at the proper length is important to minimize the risk of spinal cord injury. One can shorten up to 74% without causing injury, but if you go beyond that and get to 100% or more, so basically a vertebral body height, there's kinking of the spinal cord, and that results in injury. Here, the illustration of the resection. Multiple ribs are resected. We take the lamina away. The pedicles are resected bilaterally, and subperiosteal dissection out to the front of the vertebra is done. Discectomies above and below, and then eventually, after subperiosteal dissection, eventually resection. And you can use a burr to do this. I tend to use an osteotome and save the bone and place a cage anteriorly, and again, there's fulcrum correction. Here, my first vertebral column resection I actually performed in Cairo about 15 years ago, and this was a post-TB kyphosis. And then enjoying the shisha and a coffee at El Fishawi Cafe. And here's the patient. Here's another case of Pott's disease. This was treated. Patient had quiescent disease after a 3-drug regimen and presented with gait disturbance and weakness, bilateral ankle clonus. Here's the picture. And we performed, well, we were planning to perform a resection, but as we were just getting into the VCR, before we really completed it, we noted a bilateral decrease in somatosensory and motor evoked potential. We raised the blood pressure and placed 2 rods and aborted surgery at that time. That was 5 hours into the procedure and 1,500 cc's of blood loss. Patient was subsequently brought back. Here are some intraoperative photographs showing the angular deformity, and you can see it looked like caseating necrosis, but this was a sterile abscess essentially that presented itself after exposure of the anterior column. And we place screws proximally. Screws are placed proximally and distally. We have foundations, and then here a temporizing rod, most importantly. And we excavate underneath, excavate below, and resect. And you can see the corrections achieved with a 2-rod construct here. And we can work underneath, so it's actually helpful to have 2 temporizing rods and working underneath the spinal cord and resecting using an osteotome in this case. And here we take 1 rod out, we under contour it, replace it, do the same with the second one, and then we can compress against the screws and obtain shortening of the column over a cage fulcrum. We like to, at times, especially with kyphosis, to place a opened up titanium cage over the spinal cord defect, and you can lay bone graft over that. This protects the spinal cord from impact, especially in a very thin patient. And here's the before and after with satisfactory correction. Here's another patient. You can see this angular deformity. And working under the spinal cord with a temporizing rod in place. Postoperative correction, and this was a congenital kyphosis. Here's another failure of segmentation. A patient I recently operated on, a 23-month-old girl with progressive kyphosis, and our desire is to achieve a short segment fusion. These patients can develop secondary curves even after correction, so they have to be followed very closely over the course of their growing years. We've had the benefit recently of the use of spinal navigation over the last several years in at our institution, and I like it for small children, especially in complex anatomy. We can place our screws with the assistance of the navigation. So place as long and wide a diameter screw with foundation proximally and distally. Excavate below the spinal cord. Remove the lamina. And here's the spinal cord is exposed. We've taken the pedicles down. And then resect the lateral wall and pedicle, protecting the spinal cord. And then an osteotome, proximal and distal, to remove the hemivertebra in large chunks. And you see we have a temporizing rod. Once we've resected the one side, we still have the intact contiguous hemivertebra on the other side so that it's not destabilized. And then we can work and take down the lateral wall and remainder of the hemi from the contralateral side. And then rods are both placed and compression is performed. With very small pedicles, one can compress against ribs, or you can use a foundation where you have an outrigger rod, and I'll show you that in my next talk on osteotomies. And here we have our correction immediately post-operative in the first direct x-ray. Here's another very complex failure of segmentation. And we're taking down the pedicle here. Spinal cord is exposed. And here we did a 4-rod construct with cantilever reduction, and we don't use that type of maneuver anymore because you can stretch and translate the spinal cord and neural elements, and that's a dangerous maneuver. But here we are, we docked and closed down the osteotomy site, and a satisfactory correction from 90-degree or more kyphosis, nearly 100 degrees, down to about 40 or 45 degrees. Here's another unusual combination of Ehlers-Danlos and what we believe was a congenital kyphosis, but it can look like a lot of different things, including tuberculosis. And here we've done a resection with a titanium mesh cage. And this patient did very well clinically. Here's a postoperative CT scan showing healing, but it's very complex deformity. Sometimes we create our own angular kyphosis through perhaps imperfect execution of a standard scoliosis AIS procedure. This patient was fused flat, and she developed a progressive and severe junctional kyphosis of 51 degrees focally. And here we've done multiple posterior column osteotomies through the fusion mass in order to improve her kyphosis, and then the plan was to, you can see the motion, okay? The motion intraoperatively that we achieved. Our plan was to restore kyphosis so that she wouldn't develop it further kyphosis above our, okay? Above our extension. So we needed to release the ankylosed segment above, and we did this by removing a rib and putting an osteotome in the disc space and helping to mobilize the spine. That's what I need to get. And that mobilization was very helpful. And here we're doing a cantilever reduction where we're fixing the rod proximally and across the osteotomy site. The patient's in Gardner-Wells tongs, and we're captured across the osteotomy site and just reducing the rod slowly. And here we've restored her alignment nicely. We've increased her kyphosis and fused up to T7, previously to T3 proximally. And the PJK is now normalized to 10 degrees. And here she is. In our complex cases in Africa, we had for our kyphosis patients, a mean kyphosis of 108 degrees and corrected this to 60 degrees with the combination of techniques, including vertebral column resection in this paper, with improvements in the SRS scores, especially self-image. and most of the patients did well. Some had gait difficulties preoperatively, and many of those were improved following surgery, but not in all cases. Keep in mind the deformity angular ratio, especially in the sagittal plane. I mentioned this in my talk on neurological safety. This is important. These patients are at greatest risk, especially with a very angular deformity. And that discussion of that is important so that the families have realistic expectations of what to expect. And in Larry Lenke's series, 5% postoperative neurological complications for severe spinal deformity with VCR, and loss of intraoperative monitoring in almost 1 in 5 patients. Patients can have, especially pediatric patients, can have a small increase in improvement in their forced vital capacity and FEV1. Adults rarely do have improvement, but perhaps you can stabilize their pulmonary function. So angular kyphosis is relatively uncommon and it's diverse in its etiologies. The mainstay of treatment is vertebral column resection. Patients with a higher deformity angular ratio are at increased risk, and it's important to maintain a mean arterial pressure, use temporizing rods, and experience and training are the key. Thank you.
Thank you, Baron. Mustafa, I think we will continue with the scheduled time, with the scheduled lecture. So please play the recorded lecture of Dr. Baron.
Well, it's nice to be here again for the next talk, and this is on tips for avoiding complications during osteotomies. Some overlap with my prior 2 talks, but hopefully you, my dear colleagues, you find this, I hope you find this useful. So there are some things I will not get into too much detail on, but clearly in preparing our patients, we've got to optimize them medically. I think improving their conditioning and their core strength and gluteal muscle strength prior to surgery can be very, very helpful. Deconditioned patients probably don't recover as well and do as well. So these are things that are part of preoperative planning. But really, what we would like to do is achieve our goals, ideally with the least complex procedure to do this. Now, sometimes we don't have a choice but to perform a vertebral column resection to shorten a very angular deformity. But really, it's important to have a plan and stick to it so that your patient will realize the benefits of a well-devised plan to achieve alignment goals. And don't take on cases beyond your proficiency level. Go through the training that I spoke about in the neurological safety talk. So safety neurologically is primary concern, improvement in fixation to achieve alignment goals. If we get plowing of screws or loosening or pull out because of inadequate strategies or poor bone quality, we're not going to be able to achieve our goals. And blood loss control, I'll just touch on this briefly. So the osteotomy grades are known to you all, the Schwab SRS grading with grade 2, posterior column osteotomy is really a workhorse, grade 3, a pedicle subtraction, 4, a pedicle subtraction with the disc above, 5, 1 level VCR, and 6 is more than 1 level VCR. So what is the best procedure? I showed this patient in my prior talk on delayed neurological deficit. we performed an anterior vertebral anterior discectomies through a video-assisted thoracoscopic procedure, severe deformity, multiple posterior column osteotomies, and then 1 week later we brought her back for a fusion. And she had a lot of lability in terms of the motor evoked potential and somatosensory. And we did multiple wake-up tests, which were normal. But then she developed the postoperative deficit 20 hours later. We took her back to the OR, removed the implants, and then subsequently returned several weeks later to OR for definitive stabilization. And she still, 2 years following this procedure, had, although return of her strength, she had a spastic gait and neurogenic bladder. So I think in retrospect, and in those days we really weren't doing this, this is nearly 20 years ago, a vertebral column resection would have been a better choice. So I spoke about earlier the importance of achieving adequate fixation. Sometimes it's best to have work with foundations, so a proximal and a distal foundation, and you can compress and distract off of these outrigger rods. And this, I think, is very helpful. And you can also use them to stabilize when performing a 3-column osteotomy. It's really important when we're resecting that we palpate the foramina when we do a pedicle subtraction. And again, the establishment of these adequate foundations and adequate anchorage points is really important. You recall the data from the focus classification on the complexity of the procedure and how neurological complications increase. So, but when you have an angular deformity, there's really only one operation, and that's, for the most part, it's a vertebral column resection, although the rib, palisading rib grafts can be used in the front, as I showed for that angular kyphosis talk. As the grade of osteotomy increases, the deficits and wound infection rates increase. In this series of the Scoliosis Research Society, there were no neurological deficits, but there were only 18 VCR procedures. But for the other more complex osteotomies, the neurological deficit rate increased. So sometimes we can mitigate the procedure. Here's a girl, 111-degree curve, very rigid deformity. We performed a thoracoscopic release, at which time we performed 3 subtotal corpectomies through an anterior approach using small incisions. So we're able to shorten the spine, but not resect. And then we did concave rib osteotomies, concave rib resections, and multiple posterior column osteotomies, and we were able to achieve a very satisfactory outcome in this manner. And here, again, mitigating complexity. Rather than doing a full vertebral column resection, we did thoracoscopic release, posterior column osteotomies, and an asymmetric pedicle subtraction, so just one side. And we got a very satisfactory outcome with this. I won't spend a lot of time on this, but when we plan our osteotomies, we really got to think about what our spinopelvic alignment goals are, and they have to be age adjusted. If we're operating on older patients, we're going to leave a little less kyphosis and a little less lordosis, a little more pelvic incidence. Lumbar lordosis mismatch is the norm, and perhaps we can avoid proximal junctional kyphosis in this fashion. So age-adjusted alignment is important, and if we overcorrect, we can see proximal junctional kyphosis. These are the general goals. SVA less than 5 centimeters, pelvic tilt less than 25 degrees, T1 tilt less than 0, and lumbar lordosis pelvic incidence mismatch less than 10 degrees, but it's got to be age adjusted. Here we can achieve excellent correction with a simple grade 2 posterior column osteotomies, multiple through the fusion mass. And this patient with Marfan syndrome is well aligned. So when we analyze our patients and their malalignment, it's important to take into account local, regional, and global alignment, compensatory mechanisms used or in reserve, how strong the patient's gluteal muscles are, talked about that earlier, and the age of the patient, and our alignment goals really have to take into account all of these factors. And we've got tools in the toolbox. We want to correct and restore global alignment first and foremost. We can do that using osteotomies. We're going to fuse to the sacrum in the adult almost always. And restoring alignment correlates with health-related quality of life. And we want to correct deformity and incorporate kyphotic and degenerated segments. We want to do this through minimizing complications and morbidity of our procedures. The T1 pelvic angle, Themi Protopsaltis described this, and it's a good way of assessing your realignment, even with the patient in the prone position intraoperatively. How well have you reestablished global alignment, taking into account the pelvis and spine. Our toolbox includes osteotomies, includes anterior release. We can do lateral inner body work, posterior instrumented fusion, and then the osteotomies to achieve our goals. If we don't get it right, especially in a patient with poor gluteal muscle strength and poor core strength, as in Parkinson's, when we get it right and restore alignment on the left in this patient with Parkinson's, patient does very well. If we've inadequately restored lordosis in this patient on the right, we don't get the patient to be upright, and their overall outcome is not satisfactory. With rigid deformity and flat back, one has to do a pedicle subtraction osteotomy through otherwise fused segments. And this results in very satisfactory realignment with resulting improvement in health-related quality of life. This rigid, complex, fused failure of segmentation requires a vertebral column resection. Here's a patient who's undergone multiple surgeries, removal of implants, recurrent deformity, osteoporosis, just terrible bone quality. And we did a resection at the apex with titanium mesh at the top and fused up to C2. The alternative is to not operate on this patient, and she's had lots of problems with the soft tissue envelope and has required multiple plastic surgery procedures. But she's now more than 10 years post-operative. And here's a patient with flat back deformity, and intraoperatively we resected the pedicle, but we didn't take out the vertebra. And we thought she was realigned satisfactorily, but she really wasn't. And so we didn't stick to the plan, and she required a revision, which led to a satisfactory outcome in a more upright position. So stick with your plan. So it was important to use a stabilizing concave rod. Sometimes we'll use both bilateral rods, but for hemivertebral excision, it's got to be a concave rod. For VCR, we can have rods on both sides, and you can work around the rods. Here's a concave stabilizing rod in this vertebral column resection. You want to maintain the spine out to length. Even some shortening or stretch and lengthening can result in loss of monitoring. High rates of monitoring changes, 22%, for vertebral column resection in this series from Africa with very accomplished surgeons from around the world. Spinal cord injury of 2%, nerve root 2%. So these principles of maintaining the length of the spine, don't allow for translation, temporizing rod, maintain blood pressure, all of these are crucial. And if one incorporates more than one vertebral column resection, more than one vertebra, the rates of deficit are much higher, 8% versus 0 in Larry Lenke's series. So procedural complexity really dictates, to some extent, the risks involved in surgery. I showed this earlier. We can use halo gravity traction, and we can do a diminished operation with posterior column osteotomies and just realign the spine and give the patient good global alignment and some improvement in their deformity. Here, there's no choice for this angular, rigid, fused spine. VCR has to be done. Here, this is, again, very rigid angular deformity, and a VCR was done. I showed this earlier. You have to have a temporizing rod. Going back to this one, sometimes, this is a previously fused spine, and we talked about vertebral column resection, but instead we did Smith-Peterson osteotomies in the distal aspect of the fusion mass, and we restored general alignment for this patient. She had no paraplegia, and she did well. When you do a pedicle subtraction, it's important to palpate the foramina, the new enlarged foramen. You have to make sure that there's no bone impinging on the nerve root. This patient woke up with a quadricep deficit, and we had to take him back and repalpate and restore the foramen. Anchorage, we do this through large, long screws, different trajectories that can be used, many anchors, and we can augment with cement and sublaminar cables and wires and hooks and achieve anterior support. For our corrective maneuvers, we rely on osteotomies for the carpentry and releases to make the spine flexible. Traction can be helpful, and again, using foundations, particularly with osteopenic or osteoporotic bone, and wires and cables at the apex can be very helpful in pulling the spine to the rod. We don't always need a perfect correction. We want to kind of meet the spine halfway sometimes in order not to pull out anchors. Here, I think we didn't fuse down to the sacrum and the pelvis. We thought we could get away with this in this adult, and there's fairly rapid disc degeneration and back pain and inadequate lordosis here. So the patient needed a revision to the sacrum with osteotomy and restoration of lumbar lordosis. Interbody cages provide 3-column support and protect posterior implants and are necessary for significant kyphotic deformities. But remember, it's not just the osteotomy and local restoration of alignment. We did a good job, I think, of doing that here, but we fused short, and she developed proximal junctional kyphosis above. Hypotension can be useful in healthy patients for exposure, but then we bring the blood pressure up to minimize blood loss in that way. Meticulous dissection, dual surgeon, all of these factors have been shown to improve and lower complication rates and decrease blood loss. We use TXA as well, tranexamic acid. And we've published on the benefit of TXA in decreasing blood loss, and others have shown less blood transfusions with the use of TXA. So our take-home points are: optimize the patient, make sure they're healthy before surgery, prehabilitate, plan your realignment, stick to your plan, and maintain neurological safety with some of the approaches we've discussed. Thank you.
Thank you so much, Baron, for the presentation. And the last but not least presenter in this first webinar, Professor Dr. Walid Kashta. Dr. Walid Kashta is Associate Professor of Orthopedics in McMaster University, Canada. Dr. Walid will present a lecture regarding the syndromatic scoliosis and syndromatic deformity. Please, Dr. Walid.
Thank you very much, Dr. Mohammed, and thank you for the invitation to my home country. Talking live from Hamilton, Ontario, in Canada. I'm as you introduced me, so I'm talking about syndromic scoliosis, which is the majority of my practice is syndromic and neuromuscular scoliosis. It's not the best type of practice, but it's one of the things that we have to do. When someone asks me about syndromic scoliosis, that's my answer. So syndromic scoliosis are umbrella of cases that includes the majority of non-idiopathic scoliosis. There is no definitive types, but it includes most of the chromosomal abnormalities, most of the syndromes that can be categorized under any other categories other than the idiopathic. We'll talk about some of them soon, but they are very complex because it's not only isolated scoliosis or spinal deformity, it's a multi-system involvement of the disease. And the complication rates may exceed 25% and sometimes more. And multidisciplinary approach is mandatory to minimize the risk of complications. Here is a list of some of the syndromes. This is not all the syndromes under syndromic scoliosis, but I get this list from the SRS website. Although Marfan syndrome, we know it's a connective tissue disorder, but it's still categorized under syndromic scoliosis. Ehlers-Danlos still another connective tissue disorder, other connective tissue disorders as well. Although muscular dystrophy is categorized under syndromic, can be categorized under neuromuscular as well. Osteochondral dystrophy is another category of syndromes. Neurofibromatosis, Noonan syndrome, Vetter syndrome, Angelman syndrome, Rett syndrome, Prader-Willi syndrome, osteogenesis imperfecta, trisomy 21, and others and others. And if you look at this list, they collect all the complex cases under the syndromic scoliosis. And each one of these need a special lecture to talk about because there is a general concepts and issues and concerns, plus there are also specific concepts and concerns related to each of these syndromes. For example, for Marfan syndrome, there are mostly cardiac and cardiovascular concerns, while in Rett syndrome, mainly seizures and medication issues. Osteogenesis imperfecta has its own issues that can be non-musculoskeletal or associated musculoskeletal issues, and so on for the other syndromes. We'll focus on the general considerations today, and we'll follow some case presentations. The general considerations, we need to have a good history. Preoperative evaluation with a comprehensive medical history and review of the systems is mandatory in these cases. And from the history, make sure you look at the medication records. It's very common with the syndromic scoliosis to be under medications. They do have seizures, they do have cardiopulmonary problems, or other medications. And also, when you get the history, sometimes you get a clue from the medication rather than getting history of the system involvement. Nutritional status and if the patient has a G-tube or not, that's very important and helpful for the perioperative planning. History of recurrent pneumonia, aspiration pneumonia, and the history of hospital admission. I've seen this many times. Past surgical history, how many surgeries you had and how was the anesthetic and how was the recovery from anesthesia, how was the intubation. It's also one of our responsibilities. Is the patient ambulatory or non-ambulatory? That help us for the decision making. Other systems involvement, heart, kidneys, lungs, neuro, all these are very important to look for. Cardiopulmonary system review must be exhaustive. I know we don't do this, but we can send to pediatric cardiologist and respirologist. Respiratory disease and pulmonary complications are very common in syndromic scoliosis. And for the parents and for the patients' expectations post-operatively, we need to talk to them in details about these issues. For the expectation, I say, you'll go to ICU post-operatively and you might need a long-term support for respiration. Some stay in a PPAP. Some might need trach. Most of them will do fine, especially when we do the preoperative planning. Ask about sleep apnea, history of pneumonia, asthma, especially the aspiration events, and history of prolonged intubation. I always consult the pulmonologist, and they do the pulmonary function test for most of the syndromic cases. Plus, we talk about the cardiologist. Cardiomyopathy is common, valve problems. We talk about Marfan and how common is this with the Marfan. They do echocardiogram recently. Sometimes they do a specific cardiac MRI. Neurology is a very important and associated closely to syndromic scoliosis. Have to be a very good friend to your neurosurgery colleague. Some of them have history of seizures. Some are on valproic acid. Rett syndrome usually have uncontrolled seizures and they get controlled with the valproic acid. But you know that valproic acid increases risk of bleeding. So I have to be prepared. Ask the neurologist if he can replace it preoperatively, or we have to make sure that we might need a lot of blood supplements intraoperatively. Bladder dysfunction are at high risk of infection. And sometimes we need to do indwelling catheters. And also we make sure to have adhesive sealed dressing. Otherwise, you can contaminate the wound. Some of the kids with syndromes have hydrocephalus, and they need neurosurgery assessment. Sometimes they get the shunt has been blocked, and there are some reported cases of death for scoliosis repair because of increased intracranial pressure. Again, intraspinal abnormality, similar to the congenital scoliosis or kyphosis. You can have in syndromes, you can have tethered cord, you can have diastematomyelia or split cord syndrome or syrinx, KRI malformation, dural ectasia. All these things can happen. That's why it's essential to get an MRI. Remember, malignant hyperthermia is common with these conditions. Look for it with osteogenesis imperfecta, Duchenne muscle dystrophy, and Becker dystrophy. Osteopenia and osteoporosis. It's a generalized concept and also localized for the surgical planning. It's common with the osteogenesis imperfecta and also on other patients on medications can cause decreased bone density, especially the steroids. Eye and ear vision problems. Just look for ophthalmology consultation, and especially some reported cases after long surgery can get post-operative blindness. It's reported in few cases, but it's good to check preoperatively. Some kids come with trochlear implants, and these kids we can't apply halo traction, and or we might plan the halo traction to avoid the areas that has a trochlear implant. We need to look at these things. We'll go for surgical planning just as a general concept. Halo traction is your friend. Many of these cases present with a very severe deformity, kyphoscoliosis or scoliosis, and they have other abnormalities. The pedicles are not well formed. They have severe dysplasia, and they're very sick. They have comorbidities. It's a very good idea to have preoperative traction for a few weeks or even few months. Remember when I did my fellowship at the Shriners Montreal, they have the largest number of osteogenesis imperfecta. You see the word full of these patients with the halo traction. Consider growing rods in younger kids. Either traditional growing rods or Sheila or locutroly or magnetic rods. I prefer the magnetic rods to decrease the number of surgeries, especially with these kids, because of the comorbidities they have. Consider all your tricks for surgery. Get all your skills with you, either to go anterior, posterior, the VCRs, the osteotomies, the facetectomies, make a 3D print. That's very helpful, especially in the very rare syndromic complex cases. I'm very fortunate to work with a complex care team here at McMaster, and we meet monthly. I actually have a meeting with them after this webinar. So they include myself and the pediatrician, ICU, occupational therapist, physiotherapist, dietitian, and the neuromuscular specialist, the nursing staff, and sometimes the anesthesiologist attend, so we can discuss the details of surgery and put the puzzles together. Consider the intraoperative traction. It's a very good tool. I use the Gardner-Wells tongues, and I use the skin traction. Some people use a skeletal traction, but I change it to skin traction and get the same results. Steve Lewis in Toronto keeps putting weight until he loses the signals. I don't do this. I just go with maximum 20% of the body weight of the patient. Some people go for up to 50%. Consider the cell saver and tranexamic acid. We use the cell saver routinely in our institute, so we can get most of the blood from the surgical incision during the whole surgery, and we recirculate the blood to the patient again. And here is a cell saver machine. Tranexamic acid is always our friend to decrease the bleeding tendency, and most of the syndromic cases bleeds more than usual. Neuromonitoring, always there, and especially there is a high chance with these cases to lose motors. So you follow all the steps for losing the motors. So get all the blood pressure up, and especially the mean, and make sure the patient temperature is optimized. Fluids are fine, hemoglobin is okay, and then you reverse the last steps you have done before you losing your motors. Positioning is very tricky and essential in these cases. They're not only having scoliosis, they have other issues. They have sometimes hip flexion deformity, knee flexion deformity, arms are very tight, everything not easy. So you have to make your bed suitable for all of these deformities, and you make sure you have well padding. Imaging, let's get the imaging with the C-arm, always the tool, and O-arm navigation system if it's available. It's very helpful for these kind of complex cases. Always consider going to the pelvis if you need. And if you need to go to pelvis, consider the S2 iliac screw. And it's, of course, super easy to do it with the navigation system, but it's one of the most important tools to avoid connectors. I'll start with some cases. This is actually, I've done this case with Dr. Hawari in Halifax when I did my fellowship. It was about 10, 11 years ago. It's a first Sheila case in Canada. This was a 6-year-old female who had a spondyloepiphyseal dysplasia punctata and tether cord. She had other comorbidities, including deafness and get progressive kyphoscoliosis. She came from another country. So we planned the surgery with a neurosurgeon to come first and do the detethering. And then we followed him with anterior release. And at the same time, we inserted the screws posteriorly, and we applied the halo traction, and we put her in traction for about 6 weeks before we go for definitive posterior spinal fusion. Here is a 3D CT, and actually we did a model for a 3D print for this case. And after detethering, we inserted the screws posteriorly, and we applied the halo. And after 6 weeks, came back and inserted the rods posteriorly. The reason to wait to put the screws first, because her bone was so soft, and this way you might get some good purchase of the screws while waiting with the traction to get some correction. To avoid any pull out of the foundations, especially at the top. The second case is a 10-year-old who had a congenital myopathy. And this patient was in a horrible life. He used to be admitted with recurrent pneumonia, and he had nutritional problems, losing a lot of weight. Initially I was hoping to do any kind of growing rods for him, but he reached 10, and at this age, I said, you know what, he needs one surgery. So I talked to them about fusion. So I did a posterior spinal fusion, T2 to pelvis, used the intraoperative traction, and went for S2 screws, makes the rod go to the screws in one line, no need for connectors. Did multiple facetectomies, he didn't need any osteotomies, and he did very well. And as he mentioned that his life has been changed since he had the posterior spinal fusion. The third case is 8 years old who had a congenital Marfan syndrome, and of course get cardiac problems associated with. Her curve is not horrible, it's about 60 degrees. And this is one of the kids I offered a magic rod on, did intraoperative traction, and applied the magnetic rod. And she did her first lengthening actually in July 5th this month. Case number 4, this is another patient, was 6 years old. She had a chromosomal abnormality. She came with a progressive scoliosis. Her associated comorbidities, she's autistic and had an anxiety. She screams in the clinic whenever she comes. So this patient has been in halo traction for actually 3 months before surgery, and then was one of the good candidates to have a magnetic rod. And then we applied a brace on her because she's unreliable. She also had the first lengthening in July 5th. Case number 4, it's one of the complex cases. She has neurofibromatosis type 1, and she's 14 now. I don't know how she got missed, but one of my colleagues did this case, and I helped him over the last year. And she came with this horrible deformity with severe kyphoscoliosis. So we thought about the planning with this patient who had in the MRI dural ectasia and multiple neurofibromas around the spine. And everywhere you plan for any screws, there is a neurofibroma beside you, and we know that they have a lot of risk of complications, including dural tear, and also they have a risk of loss of neuro monitoring. So the plan was halo traction for about 4 months until she gets reasonable alignment, and then went anterior, did anterior discectomies and vascularized fibular graft, and then we did a posterior fusion at the same setting. Case number 5, this was a 14 years old, had a Rett syndrome, and Rett syndrome is very close to cerebral palsy, but most of the cases I've seen are ambulatory, and they have a good function. But it's interesting, they get a lot of trunk shift, and they lose the balance. So she had this curve of about 70 degrees, and she had uncontrolled seizures, only controlled in valproic acid. We talk about the risk of bleeding with valproic acid. I talked to neurologists to stop the valproic acid preoperatively or change it to another medication. And we did posterior spinal fusion with intraoperative traction. So for the home messages, syndromic scoliosis are complex. You need to work with multidisciplinary team, make sure you have a full institute. And number 3, you need to address perioperative general concerns and the disease-specific concerns. Thank you very much.
Thank you so much, Professor Walid, for your nice presentation. We enjoyed it so much. And we open the floor for discussion and comments from the panelists. And for the attendees, please write your questions in question and answer box, and we will look after it.
I have a comment.
Okay, please, Dr.
Walid. I think after showing these complex cases where nobody wants to touch them, you should change the name of the university from McMaster to McMastery.
Yeah, they call McMaster engineering. They call it McMaster because they have a lot of Egyptian engineers. So probably would change the orthopedic as well.
Okay, thank you.
May I start by asking Dr. Wael Qubtan? Dr. Wael.
Yes, Mohammed, I'm with you, sir.
Thank you so much for your nice talks, but I'd like to ask you regarding the screw density in Sherman kyphosis. You rely on all the screws, you avoid putting the screws at the apex. What is the screw density in the Sherman kyphosis correction in your hands?
Actually, this is an excellent question. Ideal, you should instrument every vertebra. This is what everybody does. But we did this technique where we placed 8 screws proximally and 8 screws distally. This allowed a more economic construct, and it gave us more surface area for grafting in this region, the region in between the screws. And it did not affect the stability. But are you still with me, Dr. Khattab?
Yes, we lost the signal, but we can hear you now.
Nowadays, if I will do this surgery, I will definitely try to place screws in between, possibly alternating screws at the apex. I will not instrument every vertebra, but at least I'll put a screw at least one screw in every vertebra.
Okay, Dr. Wael, how to overcome the pseudoarthrosis rate in neurofibromatosis?
That's another very good question. The only way is by grafting as much as you can. Very thorough decortication, and put as much graft as you can. And we brace these patients. Unlike idiopathic scoliosis patients, we brace them, and with bracing and excessive grafting, well, you hope for the best.
Okay. May I ask Dr. Muaz Al-Ghadir? Dr. Muaz, are you attending with us? May I direct this question to you, Dr. Walid Kashta, as well, because you showed us some difficult syndromatic cases. You know, my question was, Dr. Muaz, is which rod you rely on during the correction maneuvers in these long C curves, in this deformity, in these syndromatic cases? Which rod? You rely on the concave rod? You rely on the convex rod? You working within the flexibility of the curve, or you need to achieve the maximum correction by doing severe forms of osteotomy? Can you show and tell us the philosophy while managing these syndromatic cases?
That's a very good point. Thanks, Dr. Muhammad. So I usually with these cases accept what I can get, and I use titanium rods. Usually start with the concave side. It's very tricky. Some of them get a severe lumbosacral lordosis, and it's very hard to get the rod reduced there. I get the reduction screws down there. We use smart links, usually use the Medtronic system. It's a very good point, because these are the cases sometimes I get a small rod on the convex side to help me at the beginning until I put the concave rod first. And then I'll go back to the convex rod for the final one. I use the titanium because it's less rigid than the cobalt chrome, and I'm not looking for a huge correction for them. I just want to get their sagittal balance and a very good trunk alignment, plus correct their pelvis obliquity.
Okay, thank you so much. Dr. Wael Al-Qasim, are you attending with us, Dr. Wael?
Yes, and actually I have a question to Dr. Muaz from Riyadh, but he didn't, I think he is not.
Yes, Dr. Muaz, he is not here.
But maybe Dr. Walid, he can also answer this question. In cases with the CP patient, the neuromuscular, with this, kids with severe spasticity, pelvis obliquity, usually, do you consider the selective dorsal rhizotomy before forward for a corrective surgery to the spine? I mean, to make the spasticity less than the pelvis obliquity, maybe it will be less.
Yeah, thanks, Dr. Wael. It's a very good question. We just started selective dorsal rhizotomy in Canada in a big program. It's actually in Toronto, our neighbors. But they have certain limited indications now, so not all the patients are qualified for selective dorsal rhizotomy. But it's a very good tool to decrease the spasticity if they're indicated. I leave the selection indications to the neurosurgeon. They have a kind of board with the neurosurgeon, neuromuscular specialist. Other than that, I ask our neuromuscular specialist to optimize and control the spasticity by any other means, whatever they do. Except some baclofen pumps, because I don't like when we do the surgery, it's in our way. But they can optimize with the medications, baclofen orally, or any other kind of medications.
Thank you.
Okay, great. Is there any comments or something to be highlighted from the panelists to our great faculty? If there is
Barry-
no, yes, Tony?
How are you? Is Barry with us live or was
Hi,
it a
Tony.
video?
You
Is
say
Barry was Barry alone? How are you, everyone?
Hi, Tony. How are you?
Good. Was Barry Loner as a video or he was live with us?
No, recorded video, Tony.
Okay, so I can ask question, basically for the panel. I really enjoyed every presentation, honestly. One question, if we can, each one of us, one of the panelists can to discuss one way to reduce rod breakage for the VCRs or aggressive PSOs. So that way we can go across if each one of us can give one little tip.
Okay, starting from Professor Hawari.
Tony, hi.
How are you,
to have
Habibi?
you. ازيك يا حبيبي. I would go for a 4-rod technique to decrease the incidence of breakage.
4-rod?
Yes.
Okay.
Yahya al-Bromboli. You are muted, Yahya. Kindly unmute yourself.
I will go for 2 cross links over the resection area.
Dr. Walid, the 2 cross links.
How the cross link is gonna reduce the pseudo?
There are some papers saying that if you put 2 cross links with the anterior support, it will like distribute the stresses more evenly, so it reduces the micromotion that could cause the breakage.
Would you be concerned about the pseudoarthrosis from the cross links?
Well, it's just behind the resection area where there is an anterior mesh graft, so I would probably aim for an anterior fusion at that area. So I don't think that the cross link will affect the anterior fusion, but it will increase the construct stiffness, so possibly in decreasing the rate of breakage.
Dr. Walid Kashta.
I'm kind of like Dr. Yahya, so I do the cross links. I put the graft under the cross link to make sure that I have enough grafting, even put more for the point of pseudoarthrosis. It's a very valid point, but that's the way we do.
Dr. Wael Al-Qasim.
For me, don't agree with the cross-link because still I found many cases pseudoarthrosis in the cross-link area. So for the cross-link, I stopped using the cross-link, especially in osteotomy cases 3 years ago. But what I'm doing now, I'm doing in some cases, in addition to the 4 rods, 2 things. First, always I will try to add a mesh covering the dura and put a generous amount of a graft above the dura, above this mesh. Second, sometimes if anatomically the space add to me, I will add a graft lateral to the osteotomy part, and I will try to put the screws as we are doing in lateral approach before closing the osteotomy, and then finally I will lock it. So it will be 5 rod, 4 from posterior, and 1 it will be from the lateral, holding a graft anteriorly nearby the mesh if I use mesh, or the vertebral body replacement if I use it.
Okay, I'd like to remind the panelists with the Tony question. It is either in BVCR or in pedicle subtraction osteotomy, how to avoid rod breakage due to the pseudoarthrosis. Dr. Sharif Al-Ghamari, do you have something to add more to the previous answers? Dr. Wael Okuptan, I think Dr. Sharif has sometimes a problem with the internet. Dr. Wael Okuptan,
Yes, Dr.
do you have something to add?
My dear colleagues have said everything, but I tend to not to place cross connectors. We used to place them as a routine when we started the scoliosis surgery using the Isola system. And at that time, cross connectors did not really add a lot or decrease the rate of pseudoarthrosis. Actually, I tend to agree that these deny you more grafting space that can cause a pseudoarthrosis at the cross linkage. The 4-rod technique, as my dear professor, Dr. Yosfi said, it's definitely the way I would go. It provides us with more stability, and definitely this will decrease the possibility of rod breakage and pseudoarthrosis.
May I invite Dr. Walid Hekel or Professor Ihab Omran if they have.
I just want to add something, Mohammed. I mean, because one of the things also I'll add, I will not use titanium rods. I'll use cobalt chrome rods. So in these patients, yeah, I will go for a stiffer rod. In addition to all that I've mentioned before, and I personally I stopped using crosslinks, and all of the cases which showed pseudoarthrosis were happening at the level of the crosslinks. Even sometimes they said that happens because you put the crosslink and then you put the graft, so there is no graft under the crosslink. So they started to put the graft first and then put the crosslink on top of that to minimize this, and it still does happen. So the theory that it puts this rectangular construct and improves the biomechanics, but the downside that the majority of the rod breakage, you see them just above the level of the crosslinks. So I personally don't use them, and I agree with everything said. 4 rods, cobalt chrome rods. I like the idea of putting the mesh posterior. I mean, the only thing that I would have done differently, and we've seen in Dr. Lohner's cases, possibly I will use expandable cage, which has got a built-in lordosis, so that will get more correction of the kyphotic deformity. The downside that you do not have much room for the graft, so the mesh allows you to put more graft, but it does not give you that built-in. It was all of sort of like rectangular construct, but some cages, expandable cages, can have this built-in lordosis, and that can improve your kyphotic deformity correction. And then that idea of putting the mesh to protect the cord and to add more graft on top of that is also a good idea.
Okay, thank you so much. Dr. Ihab Omran, do you have something to add? Dr. Ihab? Dr. Ihab, kindly unmute yourself, and if you have something to add. Anyway, Tony, I think plus what is said by the panelists, in cases of pedicle subtraction osteotomies, some colleagues advocate to do some TLIF or applied cages above and below the osteotomy site. This is something to add. Currently, in pedicle subtraction osteotomy, I used to fix the osteotomy site alone and the other construct to cover the rest of the spine. You got what I mean? Only fixing the osteotomy site in pedicle subtraction and the rest of the spine by other construct. You can consider them forward technique, but focusing 2 separate constructs, one at the osteotomy site and one to the rest of the spine. Do you want to add something, Tony?
Basically, you're neutralizing the forces across the rod, which is doing the correction of the osteotomy.
Yes. Do you want to add something, or
no, like
answered
no, because the reason I asked, because we all face this problem, and we do more and more. Like, I agree with all comments. I use 3 or 4 rod techniques, not always 4, but depends on how much I'm doing correction. I try also, I try to do as much as I can corrections at the level above and below. So that way I'm not totally relying on the VCR. Even if you do a little bit of correction above it, a little bit of correction below it, you reduce the stress tremendously at that level. The thing also I do, I try to not to bend the rod at all at that level. because bending the rod and unbending it, it's problematic. I don't use crosslinks because crosslinks are set up for pseudoarthrosis and later on, breakage of the rod. But everybody kind of hit on the different trick, which is helpful to everyone.
Great. Actually, it was yes, Wael.
I have a last question.
Yes.
Dr. Tony and maybe the doctors, I don't know if Dr. Muhammad also, he was still with us. I saw a paper recently published about the cobalt chrome, that the cobalt chrome, it's a carcinogenic. And the paper is coming from France, Lyon. And I don't know if anybody from the panelists have any idea about this information.
I'm sorry, what is the cobalt chrome is coming from France, you said?
No. The cobalt chrome rod is carcinogenic.
Carcinogenic.
Yes,
carcinogenic.
Yeah, so
I mean,
they will stop using cobalt chrome, and this is a question that we are can use more rigid rods rather than titanium. I mean, I don't know if anybody have any ideas about this paper.
I can comment on this a little bit. If this is coming from the joint literature, not from spine literature, unless I'm missing out something. So that comes from the joint literature where you have a significant volumetric wear, and the amount of debris is significantly larger than the rod or friction, between rod and screw head. So, and even the joint literature, they found the metal wears in the lungs, and I agree with that. But they haven't, to my understanding, unless you guys know differently, they have not linked it to be clinically carcinogenic. They found the cobalt chrome particles in the lungs and the in different bodies, including the liver, but they haven't connected to a clinically cancer. But I gotta go back to the spine. I do think that the release of the particles is extremely small at the spine, because there's no friction, there's no moving surface area like in the knees and the hips.
I think I am totally agree with Tony, and the only something that we heard about that in the spine is the metallurgy in Chile concept, either using stainless steel or titanium. Yes, because the friction
and the magic rod.
time and the magic
rod. And with the magic rod, and that's why the magic rod has been on hold for a while. But I agree with Tony. This has been all done with the metal on metal surfacing and heap replacement, where they found this increased level of cobalt chrome in the blood. But I haven't come across any paper saying that it has proven that it's carcinogenic. But because if you look at the numbers of cases, millions of cases done all over the world, and we have not had any sort of like a proven case report. Maybe they have shown that sometimes in rats and some of these laboratory studies, but it has not been proven in human beings where they can find a direct correlation between that. Even those patients where they found a high level of chrome in the blood and the cobalt, and of that they couldn't find any correlation. As Tony said, they found it in the lungs, but again, found but with subclinical values. So nothing has, because definitely if there is any, as you see now, what happened with the magic rod, with little concerns that it has been all suspended. I mean, we are all facing, and I'm sure Walid Qishta is having this problem now. All of our early onset scoliosis now, we are on hold, waiting for something to happen, and then possibly going back to the conventional lengthening techniques like before. So when they have any index of suspicion about anything, even it's very trivial, especially in the pediatric age group, they get all suspended, and it will be all stopped. So I personally, I'm using different rods which are titanium, but they are the rail rods, not for the principle, but because they are as stiff as the stainless steel. But in the adult deformities, I still use the cobalt chrome, And if, of course, we get any information about any risk, we should all stop it, but nothing proven.
Okay, by this question, I will conclude the session and we'll continue with the rest of today activity.
Can I just ask one quick question for the panel to take this advantage? Sorry, Dr. Mohammed,
Okay,
if we have 30 seconds, because I have a case, Sherman kyphosis for surgery next month, and it's interesting. She's allergic to cobalt chrome, and it was a surprise. So she had metal allergy. I sent her for all the tests, and she came back with a cobalt chrome allergic. I need your advice and your thoughts for the type of rod I should use for her.
Titanium.
You can use a 6 millimeter titanium.
I mean, what?
تفضل يا دكتور يوسف، تفضل يا بيه.
You can use a 6.5 millimeter titanium rod if the tulip can accommodate this. There are several systems which allows this, or you can use a stainless steel with the titanium screws.
Yeah, thanks, Dr. Yusri. This is what I ordered.
I use something called the rail rod, transitional rail rod. It's titanium, and it is as 6.5 millimeter. So it's 5.5 millimeter, but it is as stiff as 6.5 millimeter stainless steel. So it's a different in the shape. So because all of the studies done about rods, we're talking about the rod metallurgy and the rod diameter. But also, if you check the rod shape, that also that's been proven mechanically about these rods, and I've been using it now for more than 100 cases, and they are very stiff, and they don't lose the correction like the normal titanium rods when you do the correction. And you can use it because especially if you're using a cantilever maneuver in the Sherman, they're very good in the cantilever maneuver. They don't lose, they don't get flattened when you're doing the correction. And that's another alternative we can use.
Which company is this?
It's provided by Stryker. Stryker. It is Mesa. It is used to be Mesa, but now they've been taken over by Stryker. So that's another alternative if you can have it. If you won't use a Rigidos, like Professor Hawari said, either you increase the diameter of the rod. Of course, you cannot use cobalt chrome now. And we try to avoid stainless steel. So either to get a 6.5 millimeter titanium, a beam rod, or you can use a 5.5 rail rod.
Or an answer from United Kingdom, our dear friend Dr. Mahmoud Al-Malki, full density screws with 5.5 titanium rods. Increase the anchorage point. Thank you so much.
I want to add something. Yeah. So just a technical tip for Dr. Walid. If when you're doing the cantilever technique for the Sherman kyphosis, just use the two rods simultaneously. So that will decrease the flattening out of the rod. So just instead of using one rod, then the second, just put your two rods proximally, both of them, and then just reduce them simultaneously. That will decrease the flattening out as well. That's it.
Thanks, Dr.
Really, it was a great session. I enjoyed it too much. And we'll continue with the next session. It will be correction techniques in spine deformity. We will have 3 presentations. Video from Dr. Sharif Al-Ghamri. I will present something regarding correction techniques, and we are happy to have Dr. Ihab Amran, Professor of Orthopedics and Spine Surgery from Cairo University, will present something regarding the use of traction in deformity surgery. So can we start directly this session? Dr. Sharif, are you ready? I think your presentation is recorded, or your video is recorded, Dr. Sharif.
Side. Hi everyone, this is our 3rd video now for the surgery. After putting the screws in the concave side, we measured the rod, and then after contouring the rod, now we are putting the rod in the screws. As you can see here, there are some equipment that can help us in reducing the curve. And remember, the video is in high speed. So what you see now is not really what's going on. It's more slower. Now we are trying now to put the rods on the lower part of the curve. And again, we did not expose the convex side yet. Now we use the sagittal contouring just to facilitate the insertion of the caps. Here, we still put the caps of the screws. And then rod holders are applied. After checking that the rod is enough in the levels up and levels below. Now we put all the screws on the concave side, and then we start put the screws on the convex side. And after we put the convex side, now we can use the reduction by using the sagittal we are correcting the curve now and fixing the screws. And I can see the correction from here. I hope you can see it now. So now we achieved a corrected curve. Again, we should cover the wound and check for the X-ray, for the AP and lateral views. And now we are trying to do the global reduction. We use these tools to give us a global correction of the curve. You can see the surgeon now is correcting the curve to this side, and then the achieve the correction, and then we fix the gaps and screws. Thank you for today.
Thank you so much, Dr. Sharif, for your illustrative video regarding different types of correction maneuvers. I'd like, before starting to asking the panel, I'd like to hear from Professor Dr. Ihab Omran, his presentation. Dr. Ihab, is Dr. Ihab is with us? I am not sure. Anyway, so we'll start by asking the panel, and if Dr. Ihab joined us again, we will hear from him traction and how he used it to help the deformity correction. And at the end, I will conclude the session by my presentation about the correction techniques. Professor Yusri, I'd like to ask you, I will start from the last maneuver of technique that they did, which is a derotation technique. What is the contraindication of derotation technique in your hands?
If the purchase of the screws are not good in the apex, or if you start getting pull out, if you're putting your concave rod, so I wouldn't do a derotation. Also, if you're putting polyaxial screws, you know that most of the derotation would go through the tulip and it will not be transmitted to the screw. So if you want to do a real derotation, you should get a good purchase in the apical vertebrae. You should have solid screws, not the polyaxial screws.
Okay, Dr. Yusri, regarding the dissection and the rely on the concave side to achieve the maximum desired correction at the beginning, then the section of the convex side. When to do the convex side and rely on it from the beginning?
First, if you put your concave rod and then derotate in the section of the convex thoracic spine, it will be much easier. So instead of having the spine away from you, you bring it towards you. Same with the lumbar spine, but the opposite. If you put your convex rod first, and then the concave screws would you bring it up to yourself, so that if you are putting the screws, you're not going horizontal or parallel to the ground to be in the pedicle. So I would, and we've seen that by just putting the convex rod and without dissecting the concavity, when you dissect the concavity, you find that the facet joints are apart. So you can still correct without exposing the concavity.
Okay, Dr. Walid Heikel. I know that you rely on the rail rod and the transitional rail rod for as your first choice. Is the correction maneuvers differ in rail rods and in your technique other types? I mean, I think the rail rod rely on this something like the persuaders or the smart link, something like this. Yes, there is no derotation at all, right?
No. I mean, I totally. Yes, I do derotation. So, I mean, as mentioned before in the talk that Joseph mentioned, so that's what I do. So I do. I use uniplanar screws on all of the construct. I know that some use polyaxial screws at the top and the end of the construct, but I still use because if you are stopping at L3, for instance, to preserve motion segments in a double major in the link 3, and there's still some residual rotation, you need to derotate that. So if you start this as your foundation and without derotation, it will be still twisted and the patient might end with a still residual loin hump. So in that case, I still make my foundation mainly proximally as the reference point, and then do the derotation maneuver and even correct the lower instrumented vertebra and derotate it to get it maximally derotated as much as I can. I do differential rod contouring in all of the cases. So you can either eyeball it, or you can use something called patient-specific templating, where you can do it with anything like SurgiMap or Kiops, and you can measure all of the sagittal alignments, and then you can parameters, and then you can get a patient-specific rod to that specific patient, and that can be prepared for you, and then you can use it for this patient. Or generally what we do with the eyeballing technique, but I use the differential rod contouring in all of the cases. And yes, I rely on the DVR in every case. The idea about the DVR in comparison to the simple rod rotation. The simple rod rotation is very good if you are taking the convexity of the spine and put it more posterior, so that you are restoring the thoracic kyphosis, and doing vice versa in the lumbar curve. So it has a good effect on the axial component of the deformity as the DVR. The DVR has got the opposite effect. It flattens the thoracic spine, but it has got the maximum correction. And as Professor Yusri said about the polyaxial. So if you want to get any derotation, you have to use uniaxial screws. But as he said, that you have to have a good purchase of the screw and transmitting all of the forces directly to the spine and not getting lost at the tube. But there is no difference. The only difference, Muhammad, between the normal rod and the rail rod is that you have to put it exactly in the mid-sagittal plane, because if the rod rotates with you or deforms with you, sometimes you find it difficult, because I use a crimping mechanism like partial and complete locking. If it is not flattened, the rod part with the screw, you might find difficulty in locking the screws. So that's the trick about it. It's not easy to apply. And the second thing is I don't use the French benders. I hate them because of these multiple notches they create in the rod. I use the long Mark Usher benders because they get this nice smooth contouring without these multiple notches in the rod.
So Dr. Walid, I meant by rotation, rod rotation. In the railroad, you cannot rotate
simple rod rotation. No, I don't do the simple rod rotation technique.
Okay.
I put the rod in the mid-axial, yes, and I use the DVR. So yeah.
Yes, exactly. That's what I meant. Okay, great. Yeah. Dr. Yahya Al-Bromboli. Dr. Yahya, if there is a difference while managing early onset scoliosis cases while applying the growing rods when you dealing with this type of deformity, is there a difference when we compare it with adolescent idiopathic scoliosis correction?
Well, yes, for sure. The main idea in growing rods is different than the final fusion. You don't aim for a full correction in the growing rods. So you're not doing any kind of strong maneuvers, because you're just relying on 2 screws up and 2 screws down. So you rely on positional correction, and you rely maybe on intraoperative traction as well, and then you slide your rod and try to put them with the least amount of effort on it, just a little bit of distraction only, nothing more. There is no derotation, you're away from the apex, so there is no direct vertebral derotation, and then there will be residual deformity with the growing rod, but that is something that we know and we accept, planning to get maximal thoracic height for the final fusion.
One of the drawbacks of the currently present growing rods that they didn't interfere with the apex. So do you think when we interfere with the apex and try to correct it, that will be much better for the child or not?
Well, this is the idea of McCarthy when he invented the Sheila technique. So the Sheila technique is that you control the apex and allow the growth to come from up and down. So yeah, he has shown that his results are really good, but still that traditional growing rod so far is the gold standard.
Okay, great. So I can found our dear friend Professor Ihab Omran with us. So kindly, Dr. Ehab, can you share your screen and deliver your talk regarding traction in deformity surgery? It will be very interesting for us. Dr. Ehab, kindly unmute yourself and start sharing the screen from the green button in the Zoom window. Dr. Ehab, can you hear me? Unmute yourself.
Dr. Muhammad, Assalamu alaikum, everybody.
Alaikum assalam wa rahmatullahi wa barakatuh.
Yes, thank you for asking me to participate in this very interesting and very useful meeting. And I do apologize that previously my internet connection had some problems. I hope it's sorted out now.
Yes, it is quite clear voice, and we are starting seeing your presentation, Dr. Ehab, please.
All right. Okay. Traction in scoliosis. I'm going to cover this topic as like a 5-minute or 6-minute presentation, a quick presentation at the end of the day. Traction is a tool that we all know as mainly as orthopedic surgeons. It's a traditional way in orthopedic technique that we can use it in other things to correct the deformity, to reduce the fracture. We can still apply traction to the spine in deformity surgery. It's very effective in obtaining correction prior to spinal fusion. Sometimes we can use it to correct early onset scoliosis, for example, if it's applying casting techniques in a very early life. So why do we consider traction nowadays when we have complicated and sophisticated other surgical intervention techniques? When it comes to large and rigid spinal deformity that we face every day, there's always a risk in correcting these deformities at one stage or acute correction. Usually these patients present with full pulmonary functions from the rigid and early onset deformity. Correcting this type of curve, as we see in the X-ray and CT of this patient, will definitely need a type of osteotomy or a vertebral column resection. Doing such a technique has its risks and complications, not to mention or not to forget the neurological compromise that can happen with acute correction. Last but not least, the instrumentation failure that can happen with correcting such a big stiff deformity, from either difficulty in obtaining anchorage points, so if we have distorted anatomy like the case we see now, or even after we apply the correction loads, then we get failure of correction either immediately after during correction maneuvers or in the early post-operative period. So here comes the question of using traction in spinal deformity surgery, and instead of looking at this whole picture of spinal surgery, we have different tools of traction that we can utilize to correct spinal deformity. To execute traction or to apply traction, one should consider several points. What's the type of traction to be used to start with? Once this type of traction is applied, how much weight will be applied? How to apply this type of traction, for example, whether it's halo, whether it's skull tongue or cardiac tongue, or a halter traction, the side of the skull. At the same time, we can use skeletal traction in the lower limb or the pelvis. We can use skin traction in the femur. Once traction is applied, what are the frequency of neurovascular checks that should be performed, and for how long will the traction be applied, and when will we discontinue with the traction? So all these points should be considered to have a proper traction before correcting the deformity surgery. Our types of traction, mainly we can apply traction as a preoperative halo gravity traction without a prior release, then performing the posterior spinal instrumental fusion after correction. We can apply traction as a staged procedure. Can be applied after first stage anterior release. then the traction will be applied, then the final correction. The stage procedure can be nowadays a posterior release rather than an anterior release, followed by the traction, then definitive correction. And we should not forget, even if we do not apply preoperative traction, that we can always use intraoperative traction. Intraoperative traction is usually a skull femoral type of traction. The skull can be used, options of applying traction to the skull, whether it's the preoperative halo, whether it's the Gardner-Wells tongue. We can always use the Mayfield head clamp or static traction against femoral traction, which is usually a skin traction or, in few cases, skeletal femoral traction. This can always be applied in pediatric deformity surgery when it's complicated with complex surgery. And at the same time, we can still apply it in adult deformity surgery. In this case, this is a 30-year-old with failed previous multiple surgeries. And we utilized intraoperative skull tongues and femoral skin traction to aid in the correction. So when it comes to the halo gravity traction, it's a safe, effective method to obtain deformity correction preoperatively. The advantage of using the halo gravity technique that the patient acquires the upright posture during the traction period. This avoids the complications of applying traction in the supine position from using head halters and skin femoral tractions with a long duration of recumbency in bed. The indications, as we mentioned, will be severe and rigid deformities, scoliosis as well as kyphosis. Other indications, if we have a deformity like this, for example, patient presenting with a severe dystrophic type of neurofibromatosis with this patient had neurological deficit pre-op. Other indications to apply preoperative halo gravity traction if from the severe early onset deformity that we find that the patient has osteopenia that can compromise an acute instrumental correction due to metal failure. Also, sometimes we apply traction preoperatively without a release if the patient presents with a pre-existing respiratory compromise from a severe deformity or from a thoracic insufficiency syndromes. The advantage, as we said, that it's a preliminary step before surgery. We can achieve some gradual form of correction. This helps in reducing the occurrence of complications as instrumentation failure or neurological deficit that can happen from acute correction of a severe deformity, and it usually improves the respiratory function if they have chest wall deformities affecting their pulmonary function tests preoperative. The contraindications of applying the halo for traction mainly will be the absolute contraindication if we have a deficient skull bone stock to gain a proper purchase. If you look at this example, this patient had a severe stiff early onset deformity associated with bilaterally, so this indication is severe as a stock for the halo purchase. Another contraindication that is mentioned in the literature, if we have a pre-existing neurological deficit, mainly due to intracranial, intracanal, mass lesion, whether it's an extradural or intramedullary tumor. But this point is questionable because we came across several cases of post-tumor surgery deformities. For example, if we look at this 10-year-old child with an extensive spinal cord brainstem cord glioma, for which he had a previous laminectomy and biopsy and decompression, and developed progressive post-tumor laminectomy kyphosis over the years. Correcting the deformity like this acutely has some risks of sudden correction with the presence of the cord tumor that can cause further neurological compromise. At the same time, given the age of the patient, the size of his pedicles or the lateral masses for fixation that will not tolerate acute correction forces to be applied in one stage. So for this patient, despite having the core tumor, we put him in a period of traction pre-op that helped correcting the scoliosis kyphosis to a little extent. And here we can see it with aided traction. And after, this is his appearance after final instrumentation, after a period of two weeks of traction, despite having a spinal cord tumor extensively from the brainstem to the lower dorsal spinal cord. So the technique of applying a halo should be well known by any spine surgeon that is planning to do a halo application. In children, usually the bone is softer, so the number of pins should be increased, 6 to 8 pins, to distribute the loads over a large area, large surface area of the skull. Safe application points should be considered, knowing the anatomy of the skull musculature and the nerves that should be avoided during applying the halo pins. The amount of weight to be applied usually starts gradually after application of the halo, whether at the same day if it's a pre-operative halo traction, or 1 or 2 days after a posterior release and traction as a staged procedure. We start by putting weight gradually. The weight is increased every day, and we can reach weights up to 30% or sometimes 50% of the patient's body weight. Is ideal to have the proper weights that can be calculated, but if they're not present, you can always improvise in our practice by using, like for example, saline bags as we see here in this case. Usually during traction period, the weight is reduced at night by 50%. During the period the patient is put in traction, the patient is encouraged to keep the upright posture, whether it's sitting or walking, most of the day. And we ask them not to remove the traction unless they're going to the toilet, for example, or during eating, or even at night. So they keep the traction on, but can be reduced to 50% of the upright amount of weight. The duration of the traction is usually determined by the magnitude of the curve, how much correction is achieved by the traction applied. We can always check this by weekly radiographs, and in addition to the clinical evaluation of the patient's pulmonary function and neurological deficit, whether it's improving or if they develop any neurological deficit from increased excessive traction during the traction period. Just a quick example of cases that we applied traction for. This is a 13-year-old coming with neglected early onset scoliosis with a curve, a stiff curve, maybe more than 120 degrees, associated with a severe form of kyphosis. We can look at her clinical photographs showing the severe deformity and the deformity, both in the coronal and the sagittal plane. Traction was applied for about 3 weeks. We reached up to 35% or 40% of the body weight. During the traction period, the spine was partially corrected. We decided to go for the correction and carry on the traction intraoperatively using the halo femoral skin traction on both sides. It's the same up to 30% of the body weight during the surgery. That's her appearance on table, and that's her appearance after correction, even without doing the costoplasty. Another quick example that we applied traction in was a 12-year-old who presented with a 4-month history of progressive spastic paraparesis. When she presented, she was almost a walker with upper motor neuron signs. Her past history was that 7 years before her initial presentation, she was diagnosed with having a cervical dorsal lymphoma, for which she had an laminectomy followed by chemotherapy and radiotherapy. At that time, she also presented with neurological deficit that improved following surgery. But 7 years later, with the deformity progression, her second presentation was a progressive deformity associated with a spastic paraparesis. Still, the decision was to do a traction for her before doing an acute corrective surgery, or instead of doing an acute corrective surgery. 10 days of traction, we can see a good correction of the deformity. And during traction, we noticed early improvement of her neurological dysfunction. This was followed by the posterior instrumental fusion. And because of the marked deformity that was dealt with or corrected, and the junctional area with too much stresses on the instrumentation, following the posterior corrected instrumentation, we decided to go anteriorly for grafting and loop sharing just to protect our instrumentation. This patient had good neurological recovery and maintained correction. Now she's like 5 years post-op. So a quick conclusion, traction in spine deformity is a useful tool helping in deformity correction surgery, especially when it comes to severe rigid deformities. It is usually a preliminary step before operative treatment. It can be used as a staged procedure, whether it's pre-operative traction or following prior posterior release. Using traction helps to reduce the occurrence of complications like instrumentation failure or development of neurological deficit from acute correction of severe deformities. For successful use of traction, we should be aware of the technical details of applying the traction, maintaining the traction, the care of the traction pins. We should make all the equipment needed for traction available. We can use traction effectively, but should not forget that it has potential side effects like pin tract infection, whether it's from the skull or the femur. Sometimes we can lose fixation points from long standing correction, so complications still occur with traction. Needless to say, the long hospital stay that is associated with traction should be considered as well. Thank you very much.
Thank you so much, Dr. Ihab, for your nice presentation. It really adds a lot for our correction techniques. May I ask you regarding how to manage pin tract infection, Dr. Ihab?
If we have a pin tract infection in skull pin from a halo, for example, we can, if it's an early infection, we can just use local measures like cleaning the pin site. Usually we advise the patient to take a shower. We don't prevent them from taking a shower during the traction period. We also advise them to use a toothbrush, soft toothbrush with alcohol, just to remove any crusts from around the pin insertion sites. If the pin tract infection increases that cause loosening of the anchorage point, we can change the anchorage point to another hole in the halo. Or if we are approaching the end of the traction period, we can just remove the traction and go ahead with the correction procedure.
Great. Dr. Ihab, while you are presenting the cases, I didn't see neuromonitoring while you are doing the traction intraoperatively. Is there a routine for you to rely on a Stagnara wake-up test, or you rely on neuromonitoring while you are doing traction?
We use both. Some of the severe rigid scoliosis or deformity or post-tumor cases, usually they present with neurological deficits, so we don't rely on neural monitoring because we already have neurological deficit pre-op. But for ambulant patients, we definitely use the wake-up test as routine, and for a lot of them, we use the nerve monitoring intraoperatively.
Regarding the weight, Dr. Ihab, you showed us some cases underwent osteotomies or previous laminectomies, and you will do traction for them. And the others are actually version cases, I mean that none touched before.
Yes.
So the weight differ between these cases with osteotomy and the releases and the previous intervention because of the adhesions and fibrosis may tether the cord as well in previously operated patients, unlike the version one. Is the weight differ?
We usually aim to get as maximum weight as possible because they are severe stiff curves, and the more weight we can get, more correction pre-op. but usually the 30% or 50% body weight is reached gradually. We don't go for the maximum weight for the first few days after applying the traction. Sometimes we reach the maximum weight after 10 days or 2 weeks from applying the traction. And it doesn't matter whether the patient had the release or whether the traction was applied before a prior release.
Okay, what is the instructions you give to the patient to remove the weight when they face some symptoms, numbness, something like this? What is the instructions you give to the patients?
Yes, we always, a technical issue, if we put the traction on the bed, for example, we should put the head towards the corridor, not towards the wall, to be easily accessible for the patient to remove the traction at any time. So that's an issue to be considered. Another thing that when they are instructed or educated to apply or remove the traction, we always teach them to do it gently. And during application or removal, the head should be supported. So one hand of the parent or the helper removes the traction, and the other hand is supporting the head from the halo itself, just so as not to whether apply or remove the traction suddenly. We always instruct them if any neurological deficit is perceived, they start removing the traction gradually. They don't remove it suddenly. So they have the weights. They can remove 1 kilo at a time. If the neurological deficit persists, they remove the next kilo, for example, and definitely they inform us immediately to deal with them.
Okay, thank you so much, Dr. Rahab, for your presentation and for your information that you give it to us. Dr. Yahya Al-Bromboli, in early onset scoliosis cases, while you are applying the growing rod, do you rely on traction?
Well, if the deformity is severe and I'm perceiving that there will be some difficulty in application of the rod, I will do intraoperative traction. It is it will help induce the gradual correction while the patient is anesthetized. And then you put the growing rod with minimal exertion on it, so you don't strain on the screws. So if the deformity is severe I mean over 70 or 80 degrees, I will do intraoperative traction here.
Okay. Professor Yusri.
Yes.
While I am working with you, I noticed that you rely only on doing posterior release, then traction, then for 1 week, then to do the definitive procedure. Although I am sure that early in the beginning, while you are starting to practice, you rely on traction as a preoperative traction and anterior release. So why you shift from preoperative traction to traction after doing the first stage posterior osteotomies, application of screws, tractions, and definite surgery?
When I started my training in Oswestry, I worked with John O'Brien. John O'Brien introduced the anterior spine surgery in UK. He was trained by Hodgson in Hong Kong, and then he came to UK. So we started most of the cases to the anterior release. By doing more difficult cases, we found that the amount of disc you remove from the front really doesn't affect your correction. So we stopped doing the anterior release. There's nothing you cannot do from the back. From the back, you are the master. You can do everything. You can do the release. You can do the facetectomy. Even if you have the rotation much and the vertebrae in front of you, you can still do the discectomy from the back. So I would say that after the modern releases, we're doing the ponte osteotomy, the pedicle subtraction. You don't need to go from the front.
Okay, good. Dr. Walid, do you rely on traction? You showed us these cases lately presented during COVID, and you did traction only in 1 case.
Yeah. 2 cases. Yeah, because we started to see the figures that we haven't seen before, similar to what Dr. Imran has shown. Yes, I did in these 2 cases the halo gravity traction for 3 weeks, And I've noticed that the maximum correction was achieved in the first 2 weeks, and not much change in the third week. That's why I didn't go for the whole period, because I said there's no point to wait, and plus the problems of hospitalization during the COVID era, so you don't want to keep the patient in bed while there's some other COVID cases in the world. So it was only for 3 weeks. I started by 20% and I reached 30%. I didn't go for more than that. Plus the same principle of asking about the pin track infection, the best thing is to avoid it. So caring about the pin track sites just by normal saline, keep it nice and clean all of the time, and checking that the screws are, the pin tracks are tight and there is no loosening, plus the neuro observation. Which was just like done during the word round, and about the advices about any neurological symptoms to be highlighted straight away. So in these cases, I haven't faced any problems with the pin tracks or with the neurological issues. I just want to add something about what the growing rods, the magic rods, or the one that I've used. Dr. Yahya said he do the traction only in big curves, but actually I do it not necessarily intraoperative skeletal traction with halo or something. But when I put the rod, we do traction. We ask the anesthetist to put traction on the axilla, and we are putting on the iliac crest and doing this traction, fixing it the rod distally, and then doing the traction and fixing it proximally to do some intraoperative correction. The reason is that each rod has got a built-in length of lengthening. So by doing that, I have saved at least 1 or 2 centimeters of the lengthening to achieve the same result that I achieved intraoperatively. Because with the normal conventional rods, you can do the distraction intraoperatively, do some, and the patient comes with the post-op X-ray better than the pre-op X-ray. Same deformity. It doesn't look nice, and also at the same time you will lose at least meter to achieve what you have already achieved on table. It's a simple technique, and we are doing it under spinal cord monitoring. So just fix your distal screws and then do the traction and then fix the proximal screws. You will achieve better correction than what you have started with, and you have not used any of the built-in lengthening mechanism of the rod you are using.
Okay, thank you so much, Dr. Walid. Dr. Ehab, regarding the duration of traction, preoperative traction, what is the maximum duration that you apply traction for the patient? And for the intermediate stage traction, halo gravity traction after the first stage posterior release and application of the screws, you rely, what is the maximum? Is it 1 week, 2 weeks, 3 weeks? What is the maximum amount? And how long?
Traction cases?
Yes. And from your experience?
We have cases that had traction from 10 days up to 6 weeks.
As an intermediate stage?
For both of them, whether it's preoperative, whether it's preoperative or after a posterior release. Usually after 2 or 3 weeks, we get an idea by having the check X-rays whether the traction is adding benefit 2 or 3 weeks. And then after that, we find that there is little benefit added from prolonging the traction.
Okay, great. Professor Yusri, you rely on 1 week intermediate traction?
Because of the expenses and the working mainly in a private hospital, so I would rather make it less than week.
And very severe, we tend to give them done in public hospitals, so we don't have this expenses issue. Still there's expenses, but the patient don't pay it himself.
Okay, thank you so much. So if there is any comment or something to add from the panelists? If there is nothing, so may I conclude this webinar by this presentation. I will share it with you. And I'd like to thank Medtronic for supporting and sponsoring this webinar. Actually, derotation technique in scoliosis surgery or correction techniques in scoliosis surgery, as we heard from the previous 4 days and from today, it is really something deserve to study well. Scoliosis is a 3-plane deformity, and our goal is to prevent progression by fusion. And we hear that sometimes we can use vertebral body tethering to achieve fusion-less correction. Anyway, our aim is to achieve maximum correction, fusion-less levels to allow more motion to the patient, and ending by balanced trunk. We rely on identification of the rotation of the vertebral column, either clinically by the presence of rib hump or in the X-rays by identification of Nashmo method of identifying the convex and convex appearance of the pedicle, convex side appearance of the pedicle, and concave side disappearance of the pedicle. We can say that there are 7 correction maneuvers that we rely in: compression distraction, simple rod rotation, which is very helpful to most of us, except when you use a rail rod as Dr. Walid Haikal used, simultaneous double rod rotation, rod translation maneuvers, direct vertebral rotation, which is an era nowadays to correct the axial plane deformity, cantilever bending, and the vertebral coplanar alignment. These are the 7 correction maneuvers that we rely on. The spine motion is coupling motion. So when you are correcting the spine, you can achieve correction in the 3 planes at the same time. And the correction of the spine deformity, you need to be that quick, safe, simple, and apply less stress to the patient and the implant. And this can be achieved by knowing well the different types of correction maneuvers. Compression distraction, simply you can compress on the convex side and distract on the concave side. By this means you can correct the coronal side deformity. You can rely on translation of the spine to well sagittally oriented rods. You can rely on translation. You can rely on cantilever bending when you fix the rod in the proximal part of the spine, and then by pushing the rod towards the distal part of the screws. By this means you are correcting and do cantilever. Cantilever is the correction maneuver, for example, in kyphosis deformity, and we rely on cantilever post rods to decrease the stresses on our construct. In situ rod bending, like we can see here, this is the rod. After derotation by coronal in situ bender, we can translate the spine towards the midline, and by we can achieve a lot of correction in your construct. Correction, the rod simply, and it was the constant that's applied by correct the spine by rotating the rod. Primary concern of the patient. If this patient, this is a hump view, we can see here how much is the deformity and how much is the rib hump, and here after doing the correction and the rotation, how the chest wall and chest cavity become more or less symmetrical. Direct vertebral rotation is an axial plane rotation, and is the primary concern of the patient, as we said. and we need to correct the sagittal profile of the patient and the coronal profile of the patient before targeting the rotational and the axial deformity. There are two types of direct vertebral rotation, the segmental or original. In that segment, of course, in order to achieve proper axial rotation, you need to release the spine well and fix your spine by multiple anchorage point. And as we heard yesterday from screwing, the uniplanar screws are very helpful in such technique. Release either doing vasectomies and periapical ponte osteotomies can help you to achieve this releases. Also here the differential episode rod, more kyphosis are applied to the concave rod and less kyphosis to the convex side rod. This is important sign will help you a lot to achieve better control of the deformity. In a stiffer deformity, we need to use sometimes in these cases. Regarding segmental vertebral manipulation, as you will see in this short video, you start to fix the tulip and the screws in the neutral vertebra. For example, in this diagram, we stabilize L1, which is a neutral vertebrae, and then segment by segment will start to derotate the vertebra directly, like this here. We'll see in this video, we fixed the lower instrumented vertebrae, which is the neutral one and stable one as well. Then we start level by level. At each level, then we rotate segment by segment of the spine. You try to push from the convex side downward and pull from the concave side. So as we see here, we push on the convex side and we pull from the concave side. By this mean we help derotating this. And direct vertebral rotation lead to better coronal curve correction, improve the lower instrumented vertebral tilt, offer shorter fusion levels, and of course, the rotational correction can be assessed in X-rays and CT scans, as we will see in later slides. In block derotation, in this, we rely on global anchorage of the vertebrae of the deformed vertebrae in the axial plane. We anchorage it by screws, and by this smart link and the connectors, we start to derotate the spine. It's the same idea as well. You push on the concave, on the convex side, and pull from the concave side, and by this mean you derotate the vertebral bodies. After doing the derotation technique, you may apply some apical distraction on the concave side, and this will improve the kyphosis, and this is of course in the dorsal spine. While to improve the lordosis, we usually rely to compress on the convex side in the lumbar spine. The vertebral coplanar alignment technique, when your anchorage point in the vertebra, you rely of course on screw density, and these screws with connectors or crickets or something like this. You put the alignment rod and the reduction rod and the definite implantable rod in the desired sagittal profile, and try to reduce it by reduction of the rod to the spine, and by this way the spine will be correct. So scoliosis correction is a combination of maneuvers. There is nothing exclusive. No technique is superior versus the others. The endpoint influenced by many factors, either curve reducibility and flexibility, stability, the fixation, the rod bending and stiffness of the rod, and the bone quality of your patient. This is one of the cases that I did at the age of 26, and I did all screw technique for her, and I corrected the rotational element in the spine. We can see that in the X-ray by seeing the crowdness in the ribs on the concave side. Here, after the surgery, look and compare both sides, how the ribs became symmetrical, and I didn't do a costoplasty for hair. And there is a paper published how to identify the rotation in the plane X-ray. If you can see both tips of the screws medial to the rods, this that you achieved from 0 to 8 degree correction in the rotation. This means you achieved this point. If you can see the tip of the screw on the right side, the convex side is hidden by the rod, that's you have rotation from 9 to 12 degree. If there is still screws on the convex side, screw tip can be seen, that's you have rotation more than 13 degree. In this case, I achieved from 9 to 12 degree and from 0 to 8 degree at these levels. And also you can rely on the lateral view. When the rods in the lateral view are overlapped, that means you did good derotation for your patient. So my take-home message is that all three axes have to be corrected. Compression, distraction, translation, and the cantilever correct the coronal plane. Rod rotation corrects the sagittal plane. But what's actually important to the patient is the axial plane and the rib hump, which can be addressed by direct vertebral derotation. And the multimodality maneuvers are used in our practice. Thank you so much. And by this, I think we conclude this day, which is a really tough day for all of us, from 6 to nearly 11, 5 hours. And I hope we achieved our aim is to spread and exchange knowledge among spine practitioners. Thanks, Professor Yusr Al-Hawari, for leading this activity for the 5th year now. And thanks, Dr. Sharif Al-Ghamri, for doing a lot to prepare this activity. And I hope to continue the next 2 days, inshallah, with the same achievement. We start by more than 100 attendees, and now we have more than 57 for 5 hours. I believe it is achievement. Thanks for our great faculty, Dr. Walid Koshta from Canada, Dr. Walid Hekel from United Kingdom, and he is now in Mallorca enjoying his time in delivering scoliosis and learning scoliosis. Dr. Wael Al-Qasim from Arbil, Iraq, Dr. Muaz from Saudi Arabia, Dr. Khalid Farag from United Arab Emirates, Dr. Ihab Umran from Egypt, and Paron Lunar, Tony Tannouri, Dr. Wael Qubtan, all friends which are actually helped us while preparing these webinars. Thank you so much, and see you tomorrow, inshallah.
inshallah. كل سنة وانتم طيبين وشكرا جميعا.
شكرا جزيلا. السلام عليكم.
انا بس ليا سجستشن بسيط يا محمد، التوك بتاعتك والتوك يعني اتس ان اكسلنت توك. لو انت حطيت التوك اللي قالها جوزيف من لبنان اللي كانت بتتكلم عن الجزء الباي ميكانكس بتاعها والديفرنس مع التوك بتاعتك، اعتقد الاثنين دول مع بعض لو joined together it's an excellent talk to explain للجونيورز والنيو كونسلتنتس البرنسبلز بتاعت الديروتيشن، ان انت بتتكلم فيها يعني كل السبيكترم اعتقد اتغطى فيها، جزء الباي ميكانكس والساينس اللي فيها، والجزء الثاني الخاص بالبراكتيكال تكنيك وهاو تو دو ات. ف both of them if they put together I think they will cover that spectrum of which is the main part يعني how to do the corrective maneuvers. Well done.
ان شاء الله ان شاء الله. شكرا جزيلا، اشوفكم على خير ان شاء الله.
السلام عليكم.
عليكم السلام ورحمه الله وبركاته.